Good evening, Sengutuvan sir. Good evening, sir.
Good evening, Jayaraman.
Welcome, sir. Good evening, sir.
Good evening.
Welcome, my teacher, Dr. Sundaramurthy, sir. Good evening, sir.
Good afternoon, Doctor. Good afternoon, Dr. Jayaraman.
Welcome, President, sir. Good evening, sir.
Thank you. Vanakkam.
All your blessings,
Jayaraman, best of luck.
Namaste. Thank you very much, sir. Sundaramurthy, sir, my
Good evening,
teacher.
Sundaramurthy.
Thank you, sir.
Vanakkam, sir.
Dr. Sundaramurthy, your curl hair has become straight hair now.
Sir, anesthesia edum pannala, sir. Captain is always captain.
Charge குறைஞ்சிட்டு வருது.
I request all the delegates kindly mute your side mic to accept the speakers and the leaders of our IMA, those who are going to take part in that initial felicitation. Thank you, sir.
Plug இல்ல.
Request all the delegates type your name, email ID, mobile number, and your TNSB registration number for your credit points purpose, CME credit points purpose. Thank you.
Charge இருக்குதா? முதல்ல நம்பர் வந்து
Good evening. Welcome all the delegates, all our IMA members and the stalwarts of our IMA. So kindly mute your side mic. Kindly mute your mic. Type your name and email ID, TNM's registration number and the mobile number, registered mobile number for your CME credit points purpose. Thank you.
Good evening. Nandagopal here.
Good evening. Good evening. Welcome. Good evening, sir. Good evening.
Sir, good evening, sir.
Good evening, sir.
Sir, good evening, sir. Jairam, sir. Good evening, sir.
Namaste. Welcome, sir. Good evening,
sir. Sir, second sir.
எடுத்துக்கிட்டு இருக்குது. அதனால நின்னுட்டேன் இங்கே.
Okay, sir. We will just close it up, sir. Sir, President, sir.
Sendil, good evening.
Sir, good evening, sir. Travel இருக்கீங்க, sir?
ஆமா, yes.
Okay, sir. சரிங்க, sir. Yes, sir. ஒரு 2 minutes will start in, sir. Yes, sir.
Good evening, sir.
என்ன டிடி சீக்கிரம் ரெடி.
Good evening, Rajesh Babu, sir. Welcome. Good evening, sir.
Vanakkam, sir.
Namaste. Vanakkam, sir. Vanakkam, sir.
Good evening, Rajesh Babu.
Good evening, sir. Good evening.
ரேகா வந்துட்டாங்க சார். ரேகா முன்னாடி போயிட்டு sir, shall we start the meeting, sir?
Yes, sir. Mr. President.
Yes.
Yeah.
You can start.
Yes, sir. Meeting call to order. I request our CGP chairman, Dr. P. Sengutuvan, sir, to give his welcome address. Yeah, Subramanian, sir. Yes, Yeah.
Yes, sir, I'm here.
Efficient prayer.
Yes, hello.
Rekha madam, are you there, ma'am?
Yes, sir, I'll start the prayer.
Yes, madam. I request Dr. S. Rekha madam, member State Academic Committee, to give IMA prayer.
இந்த IMA prayer னு ஆரம்பிச்சிருக்காங்க. IMA prayer.
All stand up, please.
Sir.
அதுக்கு கோர்ஸ் நம்ம இங்க வந்து தட்டி விட்டுட்டே இருக்கு.
Madam, please unmute, madam. Madam, you can unmute, madam.
Okay. Yeah.
Yes, madam.
May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Thank you, madam. Now I request Dr. Subramaniam, member, academic committee, to give his Christian prayer.
Good evening, everyone. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray. Give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of burden of my suffering fellow men, and a true realization of the privilege that's mine. Take from my heart all guile and take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. Thank you. Good evening.
Thank you, sir. I request our CGP chairman, Dr. P. Sengutuvan sir, to give his welcome address.
Good evening to everybody. In this occasion of inaugural function, I welcome our respected Dr. T. Sengutuvan Forest State President, Dr. N.R.T. Tyagarajan, Honorary Secretary, and the guest of honor, Dr. Arul Raj and Dr. Kesavalu. I welcome also the course coordinators, Dr. Nandagopal, pulmonologist, consultant pulmonologist, Dr. Jayaraman, consultant pulmonologist, and Dr. Narendran, CMF or consultant. So I welcome all the delegates and participants for this inauguration of the respiratory diseases. I once again welcome all the dignitaries for this program. Thank you.
Thank you, sir. So this being our first combined meeting with our state academic committee, now we are going to inaugurate the session. So now I request our state president, Dr. T. Sendamal Parisa, to give his inaugural address and also inaugurate the fellowship course in respiratory diseases, and also followed by the CME. Thank you, sir.
Respected Chairman, CGP Dr. Sengutuvan, Chairman Academic Committee Dr. Jayaraman, Secretary IMA Tamil Nadu State Dr. N.R.T. Tyagarajan, past presidents Dr. Arul Raj, who is the instrumental to bring. Can you audible?
Yes, audible.
Audible.
Audible, sir.
Respected Dr. Past President Dr. Arul Raj, who is instrumental to bring IMA CGP to Tamil Nadu. Dr. Captain Raghavelu, who is the first CGP Secretary when IMA CGP was brought to Tamil Nadu state, brought the head office to the Tamil Nadu. Dr. Raghavelu was the first secretary of CGP.
Sir, kindly unmute, sir.
Members of academic committee, yes, audible?
Yes, sir. Yes, sir. Audible.
Dr. Rekha and Subramaniam and Dr. Rajesh, AMS secretary, and the members who are joined in the Zoom meeting. Good evening to all. First of all, I congratulate the CGP Secretary and the Chairman for this combined meeting of Academic Committee and CGP. First time. Both Academic Committee and CGP are doing very well, very well. Regularly, they are starting courses in CGP every month. In addition to that, they are conducting a very good CMEs also. Last CME, the infectious disease, nearly more than 500 doctors participated in the meeting. That is a record break in the history of IMA. More than other than that 500, 200 doctors are waiting to enter into the Zoom meeting. It's a very great achievement of CGP, and the academic committee also doing very well. They are conducting meeting every month with very good topics. This is
Sir, kindly unmute, sir. Sir, kindly unmute, sir. Sir, kindly unmute, sir.
they
Yes,
automatically become muted.
Yes, sir. Yes, sir.
At this juncture, I congratulate both the CGP team and the academic team for their wonderful academic activities. With a few words, I inaugurate the certificate course on respiratory diseases with wonderful coordination of Dr. Nandagopal. I wish you all the best. Thank you for the opportunity. Thank you.
Thank you, sir. Thank you, sir, for your good, kind appreciation. Now I request our State Secretary, Dr. NRT Tyagarajan, sir, to give his address.
Thanks, Dr. Senthil, respected President, and our former National President, Dr. Arulraj, sir, former State President, Dr. Raghavelu, sir, our Chairman of the CGP, Dr. Sengatuvan, sir, and to my dear Secretary Senthil, and to the Academic Committee Chairman Jairam, sir, and Nandagopal, and Narendran, and Rekha ma'am, and to all of you who are participating. As the President has already mentioned, that the CGP is doing amazing work through the entire year, and the last CME had a record attendance of more than 500, but we had fixed it at 500, and so we couldn't increase it. But we are going to start increasing the numbers like from 500 to 1,000, and participation, the level of participation. It was actually, the last meeting was actually shocking by numbers. More than 700 people participated, more than 700 doctors participated. The topics and the entire, they stayed throughout the entire 2 hours of the meeting. That's what was very nice. No one just wanted to just place a number and just walk out or something. The topics were so interesting, and the current topics too. We have amazing speakers on the lineup, and looking forward to the speakers by Nandagopal sir and Jayaraman sir and Narendran sir. So congrats to the entire team. Keep up this amazing work. Let's take it to the next level. And CGP over the past 2 years has transformed to like they need to function independently, in the sense they function under the aegis of the state office, but CGP has grown so big, including paramedical and the AMS, and so they would require a president already mentioned during the state council meeting, during the last state council meeting, that they need to start functioning independently. I think by the end of this year, that should and would be possible. And looking forward to work the entire year for IMA, looking forward to all your services and increased participation also in the near future. Thank you, and congrats to the entire team for making this possible. Thank you, sir.
Thank you, sir. Now I request Dr. Arulraj, sir, past President, National IMA, to give his felicitations. Thank you, sir.
Thank you, Senthil. Our energetic State President, Dr. Senthamil Pari, Secretary Tyagu, and CGP Director of Studies, Sengutuan, Secretary Dr. Sendil, and other office galaxy of office bearers of IMA Academics, Tamil Nadu State, and the galaxy of faculties, and our colleague Dr. Raghavelu, and the participants. See, IMA CGP is the pride of IMA. All of you remember that IMA is a socio-medical political body. That is how it was formed. In the year 1963, after repeated struggles, it was decided to make IMA also as an academic body. Therefore, Dr. A.K. Sinha formed three wings, one for IMA CGP for GPs, second for IMA AMS for specialists, and A.K. Sinha Institutes for Research and CME. And by that time, in 1963, IMA CGP was formed. That the founder dean was Dr. P.C. Patla. He is a well-known figure in not only India, in South Asia region. He was the founder, vice president of WONCA also. IMA is also a founder of WONCA. And after that, things were moving well. I was there as the dean from 1996 to 97. And during that period, we did a lot of things. That time only the FCGP was available. We made it into a course and we did FCGP outside India. In Malaysia, we did it. And we wanted a diploma in family medicine. No university, including our MCA, was amenable. Therefore, we imported it from Sri Lanka. And then we had even MD also. All the past secretaries of the college knows it. In 2007, with great difficulty, I was trying to grow the college, but there were a lot of obstacles at Delhi. Therefore, we all took a conscious decisions, and then we just fought in the Central Council and shifted, our IMA CGT to Chennai. That time, Doctor, if my memory goes right, Dr. Sadagopan was a secretary. All of us shouted, and then we got it to Chennai. When it came to Chennai, just give me 2 minutes because I need to give some prelude for the scientific growth of IMA CGP. There was no place. There was no place in Chennai to house the college. I'm thankful to Dr. Raghavelu, who gave his house. And he became the first secretary of the college, at its location in Chennai, India. And we used to go and stay in his house. And thankful to Madam who used to give good dosai. That is how we grew. And slowly, and Jailal came in, Ravi came in, and Abul came in, and Rajeshwar, and Gunasheran, and lot. And lot of growth was there. And not only in Akkad, we brought a journal, we brought many courses, we had the DFM from Sri Lanka. I was insisting to national headquarters to have an e-versity, that is an online versity. I wanted it to be done by IMA itself, but they were not ready. They gave it to IMA CGP. We took it forward, IMA e-versity. Now in our scam, that was also involved. Therefore, it is kept suspending. I am now pushing and I am requesting all the leaders of Tamil Nadu to push with headquarters and see that the IMA e-versity comes to limelight. That is a small history of IMA CGP. I used to call the pride of IMA is IMA CGP. Now the pride of Tamil Nadu IMA is also CGP. See why? Because there are a large number of GPs who are members. Of the roughly 4 crore members, 80% of them are GPs. And we don't have any provision for the GP upgrading their knowledge and skill. We fought with the national board and we brought family medicine national board. But there are not much takers. And we wanted MD family medicine to be brought in. It was also brought in. We pushed in. But there is no undergraduate department. Without an undergraduate department of family medicine, how MD family medicine will take up? It has not come up. Then the only resource for the GP to upscale his knowledge and skill is IMA CGP. I'm so happy that Tamil Nadu State Branch is doing very well under the leadership of Dr. Chengutuan and Sendil. And a lot of meetings are happening, a lot of structured courses. That is more important. Simply a meeting, having a food, dinner doesn't solve the problem. The current updates in the medical field has to be conveyed to the practicing GP, who is a first responder. The middle of the night, somebody has a chest pain, a cardiologist is not going to see. DM cardiology, only a GP is going there. How he should recognize a myocardial infarction, how he should do the treatment. That is, he is a first responder. And that all is being taught through this mechanism. I am so happy. I wish that this should keep on continuing and we can, request our Tamil Nadu, MGR University to accreditate some of our courses. And I am thankful that today we have a respiratory medicine, course. It is so happy. The doyens of the profession are there. I still remember I have my association and working with Professor C.N. Devanagam, who is the father of respiratory medicine in our country. And I'm sure with these three faculties, we will have an excellent disposition. Now, respiratory system, respiratory medicine has a lot of importance today, especially after COVID. After COVID, the CT scan of the chest has gone up because for classifying the disease and the complications and assessing the prognosis, it is very important. Beyond all the routine COPDs, pneumonias, pleural pathologies, media center, this is very important. Now the H3 N2 has come, that has got also a lot of respiratory problem. Therefore, for a practicing physician, this upscaling of his knowledge and skill in respiratory medicine is a must. I'm so happy IMA CGP has taken it up. Our own president is a general practitioner. I will say that with pride that he was one of the first batch members who took up DFM. In Sri Ramachandra, we used to do that. We did it for 10 years. He took it up. Now he has gone up to the ladder, up to tertiary care. Specialist, healthcare, he has grown. He is an example for all the GPs to upscale their knowledge and see that they come up they need not feel that they should, settle within a small room. No. You see our Pari, you can also come up like him. I wish with this academic upliftment, the future generations of the GPs will definitely upscale their knowledge, not only their knowledge, but their practicing skill also. That is where universal health coverage is going to come. Ladies and gentlemen, I am a witness to the signatories of, universal health coverage in Geneva. And the declaration is universal health coverage is built on primary care. Even today, our honorable PM is saying that, but we will have to induce him, push him, see that the universal health care is done under a strengthened primary care, which I am confident Tamil Nadu IMA CGP is on his way. My congratulations, appreciations, and best wishes to the team. Thank you all. Thank you all very much.
Thank you, sir.
Thank you, sir, for your elaborate speech and also regarding the history of CGP Tamil Nadu. Thank you, sir. Now I request Dr. Captain Raghavelu, sir, to give his felicitations. He is the past president, IMA TNSB. Thank you.
Respected President, Chairman Sengutvan, Faculty Secretary Sendil, and other dignitaries and specialists. I am very happy to note that course on respiratory medicine is being conducted by the CGP. And as Alroy said, in the 90s, 96, we fought. And with a lot of struggle, we brought the CGP to Tamil Nadu and that too in Chennai in my house. And I appreciate the fantastic role played by my successor, Dr. Jailar. He has tremendously laid the foundation in all walks of life of this CGP. And the subsequent secretaries built up nicely. Now you are in this stage. And regarding the respiratory medicine, if you see, most of the time, the respiratory medicine takes third or fourth seat because the primary seat goes only the cardiologist, pulse, BP, and if you see, now I have the opportunity of visiting almost all the hospitals in India. In all the cases, the respiratory rate used to be 22. So this is a regular practice. See, we can learn a lot of things by the rate of respiration and the breath sounds, the frequency, the noise, additional noise. With that, we can diagnose life-threatening conditions like the impending pulmonary edema. All these things can be easily diagnosed. As Alra said, I was working with Dr. C.N. Devanayagam for nearly 6 years at Government Hospital Thoracic Medicine, wherein I had the opportunity as an anesthetist to see the records of 25-year-old records of tuberculosis patients. And I'm happy today there is a subject on talk on tuberculosis. And the patient, the case sheet, the X-ray, 25 years back and at that time. So like that, I was able to compare. And the record keeping in Tambaram TB hospital was so excellent. And there, I had the opportunity of giving intercostal, doing the intercostal drainage. I had done about 500 intercostal drainage there, and I taught almost all the pulmonologists who came for training there. And it's similarly the fiber optic endoscopy, wherein in 1996, 90 to 96, we started the nebulization of local anesthetic before fiber optic endoscopy. Otherwise, previously, a lot of techniques, block this now, block that now, put a pressure, like that. Nebulization I did in 1990 in the Government Hospital Thoracic Medicine. Like that, respiratory medicine has got a lot of clues for diseases, particularly the acute care. Because chronic care, we all know, but acute care, if you are tuned to it, it is between life and death. So I'm happy to note that eminent speakers are going to give a lecture today. And second point is tuberculosis. We are talking about control of tuberculosis nearly 70 years. So far, we are not controlled it. It is because having there worked with the pulmonologists in the TB sanatorium, I know the treatment is mostly given by the general practitioners, wherein the right classification is not done, and even if the treatment started, proper drug dose were not given or not continued. Like that, it led to a lot of multi-drug resistant tuberculosis. So now it is in the hands of GPs only. So if at all, if you want to control tuberculosis, you have to strengthen the knowledge, the clinical mindset of the GPs. And I'm happy that we have started in the right direction. I wish the CGP many more success. Thank you very much.
Thank you, sir.
Thank you, sir. So now, before moving into the CME section, now I request our course coordinator for respiratory diseases, Dr. V. Nandagopal sir, to give an overview of the program. So kindly start screen sharing, sir. Yes.
Good evening, everyone. Good evening, all the IMA leaders. Good evening, Dr. Senthil. Good evening, Dr. Jayaraman. Good evening, Senamil Pari sir, Raghavelu sir, and Arulraj sir. Can you see my screen?
No, Nandu, not yet. Yeah, now it's going to be visible. Yeah, visible now. You can make it to full screen. Yeah.
போயிட்டு இருக்கிறேன்.
Yes.
பார்த்துட்டு பண்ணிக்கிங்க. லாகின்ல தான் விட்டுருக்கிறேன்.
I request all the delegates kindly mute your
right.
mic. Request all the delegates kindly mute your mic, sir. Thank you. Nandu, back to slide into full view. Yeah.
Sir, you can just maximize the screen, sir. Sir, are you able to do, sir? Sir, I think Sir is not in the meeting, sir. Sir, you can just start with the Sir Nandagopal, sir.
Nandu?
Sir, you can start with the meeting, sir. Then we can in between you can ask.
Okay, sir.
Yes, sir. Sir, you can start the session, sir. CME, sir. Sir, kindly unmute, sir. Yes, sir. You can start, sir.
Okay.
Sir, I come back. There was some technical glitch.
Fine, sir. Fine, sir. Sir, we can just finish up with your slides. Sir.
Okay,
Yes,
okay,
sir.
okay.
I suddenly it just vanished. Can you see it now? Hello?
Sir, we are not able
Am I
to
audible?
see,
Not audible. You, Dr. Senthil Kumar,
yes, sir.
please start the session, please.
Fine, sir. Sir, sir, we can start with the session, sir. In between,
Yes,
you can
yes.
have a slide, sir. Yes, sir. Sir, Dr. Jairam, sir, continue with your CME, sir. Thank you.
Okay. Can you all see my slide, sir? Sindhu sir, can you see my slide?
Yes, sir. Yes,
Okay,
sir. Please
okay.
proceed, sir.
So, good evening, respected State President of our IMA TNSB, Dr. Sendamil Pari, sir, and the State
Not audible.
Sir, not audible, sir.
Sir, Jairam, sir.
No.
sir, good evening. Sorry for the delay.
Yes, sir. Done, sir. Done, sir. Please proceed.
Good evening, respected State President, Dr. Sendamil Pari, sir, State Secretary, Dr. Enathiar, sir, and our senior stalwart patron of our IMA, Dr. Arunraj, sir, and Dr. Captain Rahavelu, sir, and all the senior leaders of our IMA, College of General Practitioner Chairman, Sengutuvan, sir, and the dynamic secretary of our IMA, Dr. Sendil, sir, and our academic committee members, sir, and the course coordinator of respiratory disease, Dr. Nandagopal. So all the delegates and the doctors of this special webinar organized by the College of General Practitioner as well as the academic committee of our IMA TNSB. So good evening, warm welcome to all of you for this today's webinar program. Today's webinar mainly we are going to commemorate, there is two main days. One is the World Sleep Day and World Tuberculosis Day. So these 2 days are very important for our respiratory. Every month there are a lot of health days. This month we are going to commemorate the World TB as well as Sleep Day. So thank you for this wonderful opportunity. I thank our CGP Faculty Secretary, Dr. Sindhu Kumar sir, for this wonderful arrangement to spread the knowledge of the sleep health and the tuberculosis health. So with that view into, I'll start my presentation. So March 17th is a World Sleep Day. Every year we have a theme of the Sleep Day. This year theme of World Sleep Day is sleep is essential for health. So under this topic, I'm going to talk on the snoring, obstructive sleep apnea, and its influence on the diabetes and systemic hypertension. The diabetes and systemic hypertension are the very common non-communicable NCDs. So our state president's one of the program this year is the screening, that is Avo Gavon Chelan, Varangal Gramathukku Selvom, Makkalai Thedi Maruthuvam. Mainly, we are going to give importance to the diabetes and systemic hypertension and the eye care and the women empowerment. So under this, we are going to have the webinar today. I thank for this opportunity. So you all know very well, snoring and obstructive sleep apnea also.
Sir, muted, sir. So no audio, sir.
Sir, we are not able to hear your audio.
Okay. So on and off, so host is muting the mic. Okay, right. Can you hear me? Okay, sir. Now is it okay? Yeah. To start with the presentation of the case, this is a gentleman on hypertensive drugs. There are two drugs. One is the telmisartan, other one is Stamlo. So he is not on regular medicines for BP as well as his moderate obesity also. He is having overweight. He presented to the emergency department with a history of slurring of speech and weakness of one half of the body, just 2 hours duration. So with the history, patient admitted in the emergency, evaluation done for the diagnosis of the CVA, cerebrovascular accident. So investigation proven that there is no evidence of any cerebral infarction with suggestive of a CVA, but the clinical diagnosis is the transient ischemic attack, one form of CVA. Patient was observed in neuro ICU, evaluation was done. Patient had a history of sleep apnea study done 2 years back, for which he didn't take any treatment. The BP also not under control. BP is 160, 100 and all, despite taking 2 drugs. So this patient, again, we have done an evaluation. We did a repeat sleep test, which shows a very severe obstructive sleep apnea. We advised the CPAP treatment and weight reduction and continuing the regular antihypertensive medications. Now the patient is taking regular CPAP during the sleep time. Now, BP is under well control with a single medicine. He is taking only telmisartan 40 milligram. Tamlo, he has already stopped the medication. Single drug, he is on correct medication. So this patient having a overweight, obstructive sleep apnea, uncontrolled hypertension, which leads to cerebrovascular accident. That is a transient ischemic attack. This is the one case. And the other case is again, this patient is undergoing a sleep study. This is a 58 years male who has a history of hypertension on triple drugs. So amlodipine, losartan, as well as the diuretics, 3 drugs. Despite taking 3 drugs, the BP is not under control. BP is again high of 180, 110 and all. History of snoring present. The body mass index is 30. The HbA1c level also fluctuating, 11 and more than 10. Always you must check 3 months once the HbA1c. The sugar level also is very high, fluctuating sugar level. So this patient came to us. We did a sleep study in view of snoring and overweight, uncontrolled diabetes, uncontrolled hypertension. So the sleep study reveals there is a mild to moderate obstructive sleep apnea. Again, this patient was treated with the CPAP. After using the CPAP, the BP and sugar level was well controlled. The drug-wise, from 3 drugs to a single drug. He is on maintenance only 1 drug for BP, and also low-dose insulin we are giving for the diabetes control. This is the third case. 55-year-old female patients, known diabetic and obesity, who presented to the emergency department with the acute abdomen. So investigation shows clinical radiologically patient had acute cholecystitis, calculous cholecystitis. Patient underwent laparoscopic cholecystectomy emergency. After the extubation of the patient had a respiratory distress in the form of dyspnea, tachypnea, and desaturation. So this patient required NIV care and high insulin to control the diabetic status. Then second day, so I was called to see this patient. We asked the sleep history with the bed partner, his husband, her husband. So clearly patient has a heavy, loud, habitual snoring, an excessive daytime sleepiness, and witness apneas by the husband. And we did a sleep study at the time of discharge. We showed a very severe obstructive sleep apnea. Patient was started on CPAP therapy. That is a continuous positive airway therapy after the CPAP trial. Now the patient is on regular follow-up. The sugar level, BP level, all under control. Patient is taking regular CPAP therapy during night for 4 to 5 hours. So these type of cases, which shows a very commonality of the diabetes, hypertension, and the obstructive sleep apnea. So what is the pathogenesis of the sleep apnea? So sleep apnea, which leads to glucose intolerance by the way of hypoxia and frequent arousal, sleep disturbances, which leads to a lot of catecholamine release in the system, which causes glucose intolerance and insulin resistance and type 2 diabetes mellitus. Other mechanistic links between the metabolic dysfunction and the sleep apnea diabetes are sleep apnea, which leads to sleep fragmentation. There is a disturbed sleep and intermittent hypoxia because of the narrowing of the upper airway during sleep, which leads to sympathetic activation, HPA dysregulation, and systemic inflammation, which leads to the insulin resistance and type 2 diabetes mellitus. And the intermittent hypoxia directly leads to beta cell dysfunction, which also one of the culprit behind the type 2 diabetes formation. So as per the treatment strategy, there is now enough evidence available to support the treatment of obstructive sleep apnea in patients with diabetes, leads to improvement of the disease and decreases their insulin requirements as well. More recently, several studies documented a positive treatment effect of OSA on insulin resistance and diabetic control, even within 2 nights of treatment with a CPAP. So this is the strong evidence suggests that any patient with OSA, if you give the CPAP therapy, the sugar level and BP level, everything will be controlled very nicely. As per the latest recommendation of the European Respiratory Guidelines, individuals diagnosed with the diabetes mellitus should be screened for obstructive sleep apnea, particularly when the patient has witnessed apneas, heavy snoring, or daytime sleepiness is present. So you all know very well syndrome X. There are 4 components: diabetes, hypertension, obesity, dyslipidemia. What is syndrome Z? Plus OSA along with the diabetes, hypertension, obesity, dyslipidemia, we call it a syndrome Z. This is a metabolic syndrome. OSA and diabetes, hypertension, all interlinked disease. So the common disease in the present scenario. Sleep disorder breathing. This is a common disease. As a respiratory doctor, we come across a lot of patients with the sleep disorder breathing, but in generally, this is a under-recognized, under-diagnosed, under-treated condition. Sleep disorder breathing is a spectrum of disorder characterized by ranges from snoring, upper airway resistance syndrome, obesity, hyperventilation syndrome or Pickford syndrome, and obstructive sleep apnea and hypopnea syndrome. The sleep disorders, breathing, this is a very common sleep disorder among the sleep disorders. If you take the sleep disorders, what is the insomnia? Inability to get a proper sleep, a lack of sleep is a common disease. Other one is the obstructive sleep apnea, that is sleep disorder breathing. So this is a generally under-recognized condition. Sleep disorder breathing, snoring. What is snoring? If you ask any layman, what is snoring? What's the opinion about snoring during sleep? நல்ல தூக்கம் நல்ல தூங்குறாங்க மாவ நல்ல கொரட்டை போட்டு தூங்குறாரு நல்ல அப்படிங்கிற வார்த்தை நம்ம யூஸ் பண்றோம். So யாரெல்லாம் கொரட்டை போட்டு தூங்குறாங்களோ, we doctor we know that this is obstruction of the upper airway, which leads to a lot of issues. There are 2 snoring, simple snoring and the pathological snoring. Snoring is an abnormal respiratory sound during sleep because of the turbulence of airflow in a narrowed airway, because of the vibrations of the upper airway wall, because the narrowed airway causes vibration of the airway wall, causes noisy, that is snoring. There are simple snoring due to cold, allergy and infection, which is self-limited. Within 2-3 days it will subside. Any person is having daily snoring, that is habitual snoring, we have to think in terms of sleep apnea. Sleep apnea snoring occurs due to breathing passage narrows while sleeping and produces complete blockage of the upper airway. So obstructive sleep apnea is a very common disease. By definition, recurrent episodes of partial or complete airway obstruction during sleep due to repetitive collapse of the pharynx necessitating recurrent awakening to re-establish airway patency. This is the definition of the OSA. There are 2 main events here. One is the hypopnea, that is more than 50% reduction in airflow for more than 10 seconds, or less than 50% reduction in airflow, plus or minus 3% reduction of desaturation or arousal, sleep awakening. Other one is the apnea, that is total cessation of airflow for at least 10 seconds. So this is the phenotype, clinical phenotype of the sleep apnea, obstructive sleep apnea. There are 6 phenotypes. One is the REM, rapid eye movement related sleep apnea, obesity related sleep apnea, position dependent sleep apnea. So if you lie down to sleep, supine position, especially have more snoring because of tongue fallback and all. If you do the lateral decubitus posture sleep, so we can abolish the snoring and upper airway block. This is one kind of phenotype. Other one is the apnea with the hypersomnolence type and complex apneas and asymptomatic apneas. This is the clusters of OSA. There are 3 major clusters of obstructive sleep apnea. One is the disturbed sleep group, characterized by wake up too early or wake up often during the night. This comes under the insomnia OSA group. Mainly, commonly we see it in the female populations. And other extreme group is the hypersomnolence or excessive daytime sleepiness group. This is a very common group. This is a male predominant group. In between, we have a minimally symptomatic group. There are 3 clusters of obstructive sleep apnea. This slide shows there is a pathophysiologic mechanisms and consequences of sleep apnea. There are apnea, hypopnea, which leads to sleep fragmentation, hypoxemia, negative intrathoracic pressure, which leads to sympathetic surge, hemodynamic effect on the cardiovascular system, oxidative stress, inflammation, endothelial dysfunction, hypercoagulability, endocrine dysfunction, which leads to diabetes, hypertension, arrhythmias, and coronary artery disease, cerebrovascular accident, congestive heart failure, pulmonary hypertension. The sleep fragmentation directly leads to sleepiness, accidents, and neurocognitive effect, mainly poor cognitive function, poor executive function, and poor quality of life. So these are the common clinical conditions we come across in our practice, whether you are general physician, general surgeon, anesthetist, or pediatrician, physician, whoever may be. The systemic hypertension and diabetes are one of the common disease we come across in our practice. So India is the diabetic capital in the world now, next to China. Previously China, now we are the #1 capital in diabetes mellitus. So likewise, if you take any diabetes patient, they are more prone to get the high BP also. The BP and sugar are very common comorbid conditions we come across. Along with sleep apnea is a very common disease we come across in our practice. So how to make the diagnosis of the obstructive sleep apnea? From the history wise, we have a questionnaire called a Stop-Bang questionnaire. Stop-Bang is abbreviation of the, I'll tell next slide. Epworth sleepiness scale is a scale to assess the excessive daytime sleepiness. So this is the Stop-Bang questionnaire, very clearly mentioned about the stop, S-T-O-P and B-A-N-G. Stop means, do you snore loudly? Tiredness, do you feel tired or fatigued or sleepy during daytime? Observed apneas, has anyone observed that you stop breathing or choke or gasp during sleep? High blood pressure, do you have high BP or being treated for high blood pressure? BMI is your body mass index is more than 35 kilograms per meter square. Age, are you older than 50 years? Neck circumference is your neck circumference is greater than 40 centimeter. Gender, are you male? So if the score is more than high, is a high risk of OSA is there. We have to confirm by the other confirmatory test like a sleep study. Examination, mostly sleep apnea people will be obese, 80% obese, short neck, facial abnormality, oral cavity examination, we can see clearly any tonsils or enlargement are there. In children is very important because in pediatric OSA, the common cause is adenotonsillar enlargement causing the obstructive airway disease. BP, invariably majority of the patient, we suspect BP. If you take the BP with excessive snoring and suspicious of sleep apnea, invariably BP will be high. And you check the CBG, sugar also will be high. Any patient's metabolic disease, diabetes or hypertension, sleep history is very important. You ask the patient, or you sleep well or not, or any disturbed sleep because of you are going to restroom frequently. If you ask the patient's sleep history, they will tell very clearly, yes, I have sleep disturbance, I'm not able to sleep properly, I have insomnia issue, I have snoring issue. Bed partner, usually we have to ask the sleep apnea history and all with the bed partner. You ask the patient directly, so you have to ask the house husband or wife, those who are having the disease, you must ask the bed partner. Then only we can pick it up correctly. So invariably BP will be high in the case of sleep apnea. Investigation wise, these are the confirmatory tests to find out clinical diagnosis. Sleep study, polysomnography is a gold standard test. If you want to undergo the patient undergo the surgery, if any patients, young patients or mild to moderate disease, we have to see the patient as a curative intent, for which we have to subject the patient to ENT head surgeon opinion, bariatric surgeon opinion, maxillofacial surgeon opinion for the assessment of the upper airway, mainly by the nasopharyngoscopy or drug-induced sleep endoscopy. Sleep MRI and dynamic MRI. These sleep endoscopy and dynamic MRI will clinch diagnosis. Where is the level of obstruction? Whether is it a retrocalator level or retroglass level? Based on this, ENT surgeon and the head and neck surgeon will plan the surgery meticulously such a way that we can cure the problem in 25 to 30% of sleep apnea patients. They have a lot of surgery available. I'll show the next slide. Facial capillometry are very important in a case of bony abnormalities, facial bony abnormalities like retrognathia or micrognathia. So this is the gold standard test. Sleep study, polysomnography is a gold standard. We measure these values in the sleep study evaluation. This is a single night study, overnight study, 6 to 8 hour study. So we measure the oral and nasal airflow and respiratory effort, pulse oximetry, 2-lead electrocardiography, leg and chin EMG, electromyography, electrooculography, and 2-lead electroencephalography. So this will assess very clearly what stage, what kind of sleep stages, REM stage and non-REM stage. There are a lot of stages in sleep apnea. We can pick it up all the sleep disorders from these kind of the polysomnography called a level 1 or level 2 polysomnography. From the polysomnography, we derive the value called the AHI, that is total apnea hypopnea index, total number of apneas and hypopneas divided by the total sleep time in hours. Based on this, we divide the sleep apnea OSA into mild, moderate, severe. If AHI is more than 30 within first 2 hours, we do the split polysomnography. That is first 4 hours diagnostic and remaining 4 hours is the therapeutic study. There are 4 levels of sleep study. Level 1 is a fully attended in-lab polysomnography. Level 2 is the unattended polysomnography. Level 3 is the portable study, home sleep test. Home sleep test, nowadays we are doing a lot of things in the home or bedside to diagnose the obstructive sleep apnea. Level 4 study is just a screening test, just wearable watches. We can detect whether the patient has a desaturation during sleep or not. So this is the level 3 sleep study, home sleep test. We can do it with a simple gadgets like one recorder and one disposable nasal cannula and one fingerprint pulse oximeter. From this, we can derive the value of the apnea hypopnea index. We can diagnose the OSA, what kind of OSA, whether it's mild, moderate, severe or not. So this is the level 3 study sleep report. You can see the AHI, RI, respiratory disturbance index. You can see the color coding here. The normal range is green color, yellow is the borderline, red is the disease. This patient has a mild to moderate obstructive sleep apnea. This is the graphic representation. You can see that this blue line indicates there is a airflow. This is the airflow. You can see this is a hypopnea, blue line, and this is the flattening of the line called the apnea. This apnea hypopnea index is a very important index to derive the value. Based on this, we diagnose what kind of sleep severity, whether mild, moderate, severe, or not, we can classify. This is the level 2 hospital study. You can see the EEG and EMG, other leads and all. This is the level 2 in-lab sleep study. So once you diagnose the obstructive sleep apnea, what kind of treatment we are going to give? Most of the patients, once you are diagnosed, treatment is the multimodality treatment. So chest physician, we as a pulmonologist lead the sleep team. So majority of the patient may require the CPAP trial and CPAP. CPAP is one of the most important treatment. It's a gold standard treatment, considered as a gold standard treatment. But there are a lot of issues with the CPAP. Non-adherence, they're not able to wear properly, it's a cost effect. There are so many factors. So those who are having a mild to moderate disease or young people or middle-aged people, we refer the patient for ENT and head surgeon for the curative intent. In a case of any upper airway problem, like the surgically treatable causes, or we send the patient to oral and maxillofacial surgeon in a case of retrognathia or micrognathia. In a case of morbid obesity, we send the patient to bariatric surgeon for the corrective procedures. So these are the multimodal treatment. Medical treatment for obstructive sleep apnea is the general measures. You have to usually avoid alcohol, sedative pills, hypnotic pills, and the smoking, etc. Weight loss is a very important treatment. A specific measure to increase the upper airway caliber or position therapy. Mild to moderate cases, we lie down. We tell the patient to lie down in the lateral decubitus posture. With that, we can control the disease. The positive airway pressure therapy, PAP therapy, are one of the gold standard important treatment available nowadays. CPAP, continuous positive airway pressure, or bilevel systems, BiPAP, for overlap syndrome between the COPD, severe COPD, or severe obesity hyperventilation. With OSA, we can give bilevel support. Automatic CPAP also we are suggesting, and we have oral appliances for the treatment of the obstructive sleep apnea. Positive airway pressure, PAP therapy is a gold standard. There are CPAP and BiPAP. Upper airway assessment before PAP therapy by ENT surgeon is very important. This is the full face mask. This is the gadgets we use it for the CPAP and BiPAP. CPAP, nothing but is a continuous positive airway pressure. It acts as a pneumatic splint for upper airway. So we have to use at least 4 hours per night, 5 nights in a week. So there are some mild discomfort will be there. We have to teach a patient effectively. This is Dr. Sullivan, inventor of CPAP in 1980. CPAP, nowadays we call it as a magic box. If you don't wear a mask properly during night time, if you don't take a treatment, it has a lot of major adverse reactions. Sometimes sudden death also happens during the sleep because of the hypoxia, arrhythmias, and cardiac arrest. So this is the nasal CPAP mask, and this is the nasal insert and other instrument. You can see this is a chin strap. Those who are having the open mouth breathing during sleep, we have to put the chin strap and apply the nasal pillow or nasal mask. This is the nasal insert and nasal mask and the oronasal mask. So this is the various kind of smartest CPAP system available nowadays. Coming to the non-surgical management, oral appliances, in that mandibular advancement devices and tongue retaining devices. Mainly this is for the retrognathia or micrognathia patients, and these are all the various devices available. This is the adjustable mandibular repositioning devices for the advancement procedures, mainly the retrognathia and micrognathia procedures. Roll-up surgery in sleep disorder breathing. Adenotonsillectomy in pediatric age group is a gold standard. Children suffering from the adenotonsillar hypertrophy causes obstructive sleep apnea. Mild to moderate OSA in a young or middle-aged people, we refer the patients for ENT and head and surgeon for the upper airway surgeries like lingoplasty or the co-ablation technique, etc., etc. We have a maxillomandibular advancement osteotomy for retro migrainographia, bariatric surgery for morbidly obese people. This child, 8-year-old boy, classically presents with snoring, mouth breathing. Examination found that we have there is enlargement of the adenoids, tonsils adenoids. So treatment of choices, adenotonsillectomy in children. Surgical management for the retrognathia, maxillary mandibular advancement osteotomy performed in conjunction with the oral and maxillofacial surgeon. So this is the maxillary mandibular advancement osteotomy. This is done by the maxillofacial surgeon. Bariatric surgery, if the BMI is more than 30, we refer the case to bariatric surgery. They do the gastric sleeve resection or gastric bypass procedures. To summarize, sleep disorder breathing is a common sleep disorder. Snoring and excessive daytime sleepiness are very important symptoms, and the polysomnography is a gold standard test to confirm the OSA. Syndrome is that you all know well, diabetes, hypertension, very common non-communicable disease, NCDs, dyslipidemia, obesity, plus OSA is a syndrome is it. Treatment is a multidisciplinary. We have to involve the pulmo, ENT, maxillofacial, and bariatric. So among these, the pulmonologists will lead the team of sleep medicine. So sleep is a very, very underutilized subject nowadays. But sleep is not a luxurious thing. This is a very, very essential, vital metabolic function. So we have to take care of our sleep is very, very important. So diabetes, hypertension, sleep history is very, very important. Snoring history is very, very important. Diagnosis of OSA from the questionnaire and confirmatory test is sleep study, all very important. So don't neglect snoring and sleep part. This is a very, very important thing. We want to control the diabetes and hypertension to prevent heart attack and stroke. This is very, very important. So heart attack, we say maralepu. Brain attack, we say the stroke and all. Likewise, moochadaipu, thukuthil swasadaipu. Tamil, we say thukuthil swasadaipu, obstructive sleep apnea. This is a very common comorbid conditions associated with diabetes, hypertension. The take-home message is very clear that any patient with diabetes, hypertension, so we have to looking for the sleep apnea is one of the common comorbid conditions. So with that, I end up my presentation. World Sleep Day. Every year we are doing awareness activity. In Chennai, we are doing the awareness walkathon, and the presidency of our Cinnamon Pariser is flagging up the event. So I welcome to participate in this, and in your place we do awareness activities like walkathon, cyclathon, and other activities. So with that, thank you very much for this wonderful presentation, wonderful chance for the CGP. Thank you. Thank you. Any question I will take at the end. Thank you.
Yeah, thank you, sir. Sir, now can we have the next session or some questions we'll have now, sir?
No problem. Whatever you feel, you can proceed.
Sir, because since the topics are a little different, we'll just finish up now, sir.
Okay.
So
okay.
I'm sure like most of us will be having snoring even as a individual person. So we should have also faced such issues. I think we should all be free and ask our queries to sir. So any questions from our members, kindly shoot your questions, maybe even related to OSA or even snoring. And meanwhile, there are two questions, sir, in the chat box.
Yes, sir.
Outcome of OSA treatment is better in men or women?
Yeah. See, in women, the diagnosis is slightly different from men. But the final diagnosis confirmation is the sleep study only. So both after the 45 years, men and women. So women, estrogen hormone will be somehow protective up to the age of 48, 50. So after that, so both are equally develop all the complications from the, if you don't take sleep apnea management, both are leads to a lot of complications. So among the male and female group, males are predominant of the developing the obstructive sleep apnea. If you take the history and the incidence rate and all, so male are predominantly affected by the obstructive sleep apnea. The OSA is a familial disease also. Some genetic variant also is there. So men are mostly affected by the sleep apnea, and there are various lot of factors because of alcohol. There are so many factors which contribute to the male predominance of the obstructive sleep apnea. So management is adherence is very, very important. So in this, if you adhere the management protocol correctly, if you control all the metabolic diseases like excessive weight, cholesterol, diabetes, etc., etc. Thank you. Yes, sir. Sendil?
Sir, what type of OSA is common in our population? Central, peripheral, or mixed?
Yeah. In our practice, among the sleep apnea, obstructive sleep apnea, OSA, in the OSA also predominantly male predominance, that is a hypersomnolence type. excessive daytime sleepiness, snoring group, or we are seeing a lot of things. That is the obstructive sleep apnea. In female category, predominantly we see insomnia type. That is insomnia. That is a disturbed sleep group. Female patients mostly, doctor, எனக்கு தூக்கமே சரியா வர மாட்டேங்குது, எனக்கு தூக்கம் என்ன தூங்க மாதிரி இல்லை, எனக்கு டயர்டா இருக்கு, காலையில எனக்கு ஹெடேக்கா இருக்கு, சரி எனக்கு வேலை செய்ய முடியல. So obese இருப்பாங்க, hypothyroidism இருக்கும். So we have to ask the history. The history is very, very important. Examination is very, very important, and final confirmation is the polysomnography. So this way we can approach the male and female and other etiology of the sleep apnea. Yes.
Yeah. Any other questions from our members?
Raghavil sir asking a question. Sir, you can unmute your mic and ask. Raghavil sir, Captain Raghavil sir.
Yeah. Now everyone is unmute now. Kindly post your questions now.
Captain Raghavil sir, just unmute sir. Oh, sorry sir. Yeah. From Crystal Priya, I'll ask.
Okay. Can you hear me?
Yes sir. Yes sir. Raghavil sir.
Yes, sir.
Okay. Dr. Jairam, in your presentation, the first slide, you said labs cholecystectomy done following the patient went in for respiratory failure. Is it because of the lab cholecystectomy or with sleep apnea OSA or something else?
Sir, the causative factor in that lady is because of the anesthetic agent. Anesthetic agent causes some muscle relaxations. So during the recovery period, there are a lot of bronchospasm, that is upper airway narrowing in the genioglossus part, which is the main culprit. Anesthetic agents causing the upper airway narrowing is the main cause in a postoperative case. This patient underwent a GA, general anesthesia. The anesthetic agent is the main culprit behind that. So any patients of obesity or uncontrolled diabetes, you will suspect this perioperative respiratory failure. One of the important etiologies is yes sir, please sir.
No, Dr. Jairam, on the contrary, I would say that in cases like this, obstetric sleep apnea syndrome and obesity, normally the gastric fullness will be there. There is, during the attempt of giving anesthesia, there is, during our recovery time, there is a mild regurg of the gastric content into the lungs. This is the silent regurg which is not noticed by anybody. So following anesthesia, the patient got into a lung problem. So it is not because of either the OSA or cholecystectomy. It is because of the improper preoperative preparation in anticipation. So this is expected. So you have to take preventive measures like complete emptying of the stomach or making the gastric content more neutral in acidic. So normally gastric content is very acid, no? So we have to make it neutral so that even accidental regurg should not produce any mucosal, respiratory mucosal changes. So that is the most often the cause, and we normally don't put the blame on the, so we just accept it. And we just put the blame on the anesthetic drugs, poor drugs. It is not the anesthetic drugs, it is the failure of the man behind the anesthetic drugs.
Thank you.
Thank you.
I fully agree.
Prepare ஒழுங்கா பண்ணுடாங்கறான்.
Sir, there is one more question, sir. Like from what age snoring can start, sir? Can it start from younger childhood or teen age or 20s or 30s? Any particular age pre-incidence?
Snoring, snoring is a sign. Snoring is a symptom and sign of the upper.
Sir, please unmute, sir. Please unmute, sir.
Snoring can occur in all the age groups. So upper airway problem, upper airway obstruction in children are very common because of the tonsil enlargement, adenoid enlargement. So starting from the children, we are seeing a lot of patients obstructive sleep apnea in pediatric age group. The combination is the enlargement of the tonsils, infection, inflammation of the hypertrophy of the tonsils, adenoids. And all the age groups, once age advances, the incidence of the sleep apnea will be rising because of the laxity of the upper airway muscle due to various reasons. The upper airway muscle, genioglossus, hyoglossus, all the muscle laxity will become more and more once age advances, like all the other diseases. Degenerative disease like osteoarthritis, dementia, Alzheimer's, the sleep apnea incidence also increasing. So children also common, and once age advances 55, 60, 70, the incidence of obstructive sleep apnea is a very, incidence rate is rising because of the laxity of the muscle, because of the aging. So this is the thing we are seeing in day-to-day practice. Yes, sir.
Fine, sir. Sir, Dr. K. Kalyani has, I think, has a doubt. Can you shoot your question, Dr. K. Kalyani?
What's the question, sir?
So how many days usually the CPAP is given as treatment for snoring, sir?
Ma'am, before prescribing CPAP, we have to see the patient as any curative, any correctable, any completely curable causes like retrognathia or any severe hypothyroidism or any morbid obesity. So these things we have to correct clearly. So once there is no correctable causes, no retrognathia, no micrognathia, no hypothyroidism, obesity, overweight is there, it will take time to reduce the weight and all. So these people, we have to prescribe the CPAP therapy. CPAP therapy is mostly it's a long-term, lifelong treatment also. Daily, as per the recommendation of the American Sleep Academy and the World Sleep Society, daily minimum 4 hours, maximum 6 hours we have to wear during sleep time. So 11 p.m. to 5 a.m. So this is the treatment protocol we offer. This is a long-term regular treatment. 6 months to 1 year we follow up the patients, whether the patient is using CPAP correctly or not. A lot of issues we have to tackle in between. And if the patient is reduced the weight of gross reduction of weight 10-15 kg, we repeat the sleep test after 1 year. If there is any significant reduction of the AHI, apnea hypopnea index, or normal within 5, normal means so we can stop and repeat the sleep study. We'll find out whether any residual sleep apnea is there or not. If sleep apnea is absent, so we'll stop the CPAP. Majority, the sleep apnea management is the lifelong, long-term management. Yes.
Sir, there is one more question, sir.
Yes.
In between, sir, if there is any teeth grinding in between bouts of apnea, is it part of OSA?
Correct. Now, grinding of teeth is, we call this as a bruxism. This is parasomnias. This is other sleep-related disorders. So we have effective treatment for the bruxism, grinding of teeth and all. This is not part and parcel of the sleep apnea. This is a separate neuropsychiatric manifestations of the sleep disorder. So sleep apnea manifestations predominantly the snoring, excessive daytime sleepiness, or insomnia, headache, any frequent headache, daily headache. One of the DD is the sleep apnea. Depression, because of the hypoxic encephalopathy, patient may not take a positive this thing, may end up in a sleep clinic, depression clinic, psychiatric clinic, depression, frequent road accidents. These are the so many clinical presentations. And frequency of micturition during nighttime, nocturnal polyuria. This is the various presentation. The bruxism is a different category. The restless leg syndrome is a different category of the sleep disorder. Yes.
Yeah, fine, sir. Any other questions? Sir, and meanwhile, one final advice or tips to reduce the snoring. So maybe top 5 tips, sir. Can you give some tips?
Correct. Reduce snoring, we have to treat the cause. In Tamil, Tirulur clearly said 2000 years before, Noi Nadi, Noi Mudal Nadi, Adulanikum, Vai Nadi, Vaipachayal. So snoring due to various reasons. This may be a simple reason. Nothing, snoring daily and Kadayade. Master snoring, daily snoring. So that patient need not do anything. Self-limiting, nothing to worry about that. And the simple snoring. Sleep apnea snoring is a habitual snoring. Social cause, social disturbances. In flight, train, a lot of snoring issues. Next day, husband, wife. Foreign countries, a lot of divorce happening. So snoring is an important social as well as the healthy risk issue. So we have to adequately treat the cause of snoring. Whether is it in the sleep apnea. Sleep apnea is a major cause of snoring. So any snoring daily means we have to rule out sleep apnea. Methodological history, examination, and confirmed by the sleep study, CPAP and non-CPAP treatment, weight reduction, hormonal corrections, mandibular corrections. So this is the treatment modality. This is actually snoring and sleep apnea is a complex disease, needs a multimodality treatment. So we have to carefully examine, rule out to prevent complications. The major complications of sleep apnea, if you don't treat properly, is the uncontrolled hypertension, uncontrolled diabetes, uncontrolled asthma, heart attack, stroke, cancers, and sudden death during sleep also. So we have to keep it careful, man. Yeah.
Thank you, sir. So there's one more question. Is there any role of pranayama in preventing sleep apnea?
Pranayama, yoga, and other breathing exercises are all supportive treatment. There is no curative role here. Supportive treatment. If you maintain, if you do pranayama, it's a good. the oxygen will be very high, very nice oxygen you get during pranayama, yoga, exercise and all. But during sleep is an unconscious state. You don't know what happened during sleep. So during the sleep, it happens. That's why this is obstructive sleep apnea, respiratory block, சுவாச அடைப்பு அப்படிங்க. So அதுல நமக்கு பிராணாயாமம் அதெல்லாம் நமக்கு ஹெல்ப் பண்ணாது. அதெல்லாம் ஹெல்ப் பண்ணாது. Specific treatment, treat the cause. That is very important. Yes, sir.
Thank you, sir. Any other questions? Any other questions? Kindly raise your hands or post your questions in the chat box. Fine, sir. I think we can end with the session. Thank you so much, sir.
Thank you very much for the opportunity, sir.
Yeah, thank you, sir. And now I request our course coordinator, Dr. V. Nandagopal, sir, to give a short overview about the respiratory disease certified course. Over to you, sir.
Good evening. Good evening, all the IMA leaders. Good evening, President, sir. Good evening, the CGP Wing President, Secretary, and all the IMA seniors, and our academic committee chairman, Jayaraman, sir. Let me just give you a short overview on the course, what we are going to trying to do, and with the corrections what we have placed here. Hope everyone able to see the presentation.
Yes,
so
sir.
Why, as Dr. Raghavelu sir has already mentioned, the respiratory symptoms are the most common, and there is a huge knowledge explosion in the respiratory medicine. There are newer investigations, newer medicines which are coming in, newer devices, new guidelines, which are actually changing year on year. Even from the time we did our respiratory medicine, Dr. Jayaraman sir would agree that there are a lot of changes which have happened in the last couple of decades. And if we haven't updated ourselves, I think we are practicing in the last century, if not figuratively, literally. So we need to re-expose ourselves to what is happening right now, rekindle ourselves with enthusiasm, re-educate and relearn the latest guidelines and protocol, so that we are not just on the correct, we are giving a correct treatment to our patients, that also that we are not on the wrong side of the law. So the goal of the course is to improve the diagnostic skills in chronic respiratory diseases like asthma, COPD, tuberculosis, and ILD, which are the most common diseases which we see right now, and improve the management skills of the general practitioners in tune with the current standards and guidelines. This course is largely aimed at general practitioners who have to improve, who want to improve the diagnostic skills as per the latest standards. So the course structure is now, as requested by our recommended and advised by our CGP wing, it's made as an online course. The previous course was more of a contact course, but this time it's more of an online course. But there'll be a hybrid workshop contact classes. There'll be workshops on spirometry and other aspects which can't be basically taught online, can be taught in person. So the course materials also will be mostly online. There'll be links available, and the course duration is about 6 to 8 months, and evaluation at the end of each class, and there'll be an examination at the end. The curriculum involves basics of lung anatomy, physiology, little more of X-ray interpretation, spirometry interpretation, and overview of respiratory pharmacology, of which we are going to see some of the things today with inhalation devices and techniques. Tuberculosis of pulmonary and extrapulmonary, which we can't do without tuberculosis in India. So as I said, asthma and COPD, along with infections and respiratory emergencies. And to complete the curriculum, it will be a short overview on the pleural diseases, lung cancers. The advantage this time, that since we have an online, we can involve many faculties and enthusiastic faculties like our chairman, Dr. Jayaraman. So everybody can pitch in as a faculty. So it will be easier this time with a wider quality of very experienced and qualified teachers. So this is the basic framework, which is subject to change, of course, depending on the availability of the teachers. But this is how we have planned. On most of, like it's fixed like a third Sunday of every month. We can have from a morning session from 9:30 to 1:30, about 4 hours of classes online, mostly with a small break in between. On the weekday, one of the weekdays, either between 4 to 6, which is the CGP time, or between the 7:30 to 9:30, which is not yet fixed as of now, we can have other classes, so that in 6 months to 7 months, we will finish off most of this, and we can have an exam at the end. So with a constant re-evaluation, case sharing. So this is the program which is being made out, and our CGP secretary and the president have taken great pains to ensure that this will get at least 10 credit hours, if I'm right. I think the Senthil has to confirm on this. So if at the end of the class, we'll have some 10 credit hours from TNMC, if you're attending everything in total. So that's about, along with the workshops, you have planned for workshops also. So during the course, if there is participants need something of interest, we can add those topics also if feasible. So this is the short overview, and let me stop sharing here. I'll like Dr. Senthil to chip in, because he is the architect of this.
Yes, sir. And regarding the credit hours, we can get a maximum of 10 credit hours, sir. So depending on the session and whether it is on-site or online, and also whether the candidate is attending the entire series of lectures. So it is definitely possible to get 10 credit hours, sir. We can do that, sir. Yes, sir. So, sir, Jayaraman, sir, you can just give an introduction about the next topic and take over, sir.
Oh, yes, thank you. Good evening, welcome back. I'm Dr. Jayaraman, Chairman, Academic Committee. May I introduce the speaker for this wonderful talk to commemorate this special days. Dr. V. Nandagopal, coordinator of our CGP course of respiratory disease program, and he is a consultant pulmonologist working in the Institute of Lung Care as a consultant and research center, Hindustan Hospital, Coimbatore, and is a course coordinator of our CGP course. And he is our academic committee member of our IMA TNSB. So Dr. V. Nandagopal is very well versed in academic and is a very good clinician. He is a very well asset to our IMA, and he has been a lot of programs. And from in the CGP also is connecting various programs. More than 10 years is connecting this respiratory course for our IMA members. I request all our IMA members kindly utilize this course for your update of your knowledges. So with that few introduction, may I request Dr. Nandagopal to present the topic on the inhalers. When, what, why, and how, because the inhalers are very common, very important drugs for the disease called obstructive airway disease, asthma, and COPD. So over to Dr. Nandagopal for this presentation. Over to Dr. Nandu. Thank you.
Thank you, sir. Thank you for that generous introduction. Let me just dive into the topic straight away. Inhalers, when, what, why, and how. I am part of the Institute of Lung Care group, which we have 4 senior pulmonologists. I'm the junior most with 23 years of experience. So you could guess, and 2 of them were my teachers. So let me just straight away go into the types of inhalers, because when there is a knowledge explosion and there is an inhaler explosion, there are a lot of gadgets which come in a country like us, where a lot of pharmaceutical companies are there, and they try to bring in their medication, and they say they are the best. Obviously, everyone will get confused which is the medication. I'll just give an overview about types of inhalers, then about why inhaled medicines are being used in airway diseases, and what is the type of medicines available, and how to go about it in a very simplified way for the purpose of general practice. So let me go in. There will be a bit of science, but I'll try to make it as simple as possible over the next 20 to 30 minutes. So what are the inhaled drug delivery systems available in general? Okay, the first one is the metered dose inhaler. Why it is called metered dose inhaler, or the common inhaler as it is known as? There are 120 or 200 doses in each of those canisters. When we use them, there is a proper calculated amount of dose which comes out into the patient's inhalation. So it is a calculated dose. That's why it's called metered dose. And because it needs to be inhaler, it is called metered dose inhaler, MDI in short. And if for patients who are not able to use these inhalers properly, there is an add-on device like a spacer. Spacer is something like what we see in our feeding bottle. I'll show you the picture shortly. And for kids, we can add in addition a mask, which is to be applied on the face. So this is the metered dose inhaler delivery system with an add-on devices of spacer and mask. There is a next set of device which is called a dry powder inhaler. The main difference between the metered dose inhaler and dry powder inhaler is that in metered dose inhaler, there will be an aerosol based solution, whereas in dry powder, as the name suggests, the medicine is present as a dry powder. So the dry powder needs to be inhaled inside through a device. And the third part is nebulizer. So nebulizer is, we all know, we all use it very, very commonly in our clinics. So this is something called a nebulizer, which we all seem use again and again. But what is the rationale behind using a nebulizer? We'll know in the next couple of 20 minutes. So the last is the breath actuated metered dose inhaler. So which we need to see. This is the newest of the inhalers which has come. The breath actuated metered dose inhalers are BAIs. I'll talk to you about on that also. So classification of inhaled drug delivery system, once again, it's MDI with an add-on device of spacer and mask, dry powder inhaler. In dry powder inhaler, you can actually divide them into one dose each, whereas the patient takes each dose separately and puts them in the device and actuates the device and then uses it. Or it's a multi-dose device where all the doses are stored inside and the patient does have to. Even in the multi-dose device, there is a discrete and reservoir. All these are technical terms. I'll just show you the pictures, then you'll know this is that simple. Okay, there is a unit dose DPI and multi-dose DPI. Unit dose DPI, we all know, we have used it, or we have seen our patients use it more often. Rotahaler, loopyhaler, all these halers, which you can see at the bottom of the screen, in which a separate capsule has to go in and actuate it and use it. Whereas in a multi-dose dry powder inhaler, there are two types. One on your right side is the reservoir, which is called a turbohaler or novelizer, in which all the doses are put inside as a powder form in a single reservoir chamber. In that, the frequent one particular amount of drug will come out. Whereas in discrete or a single pre-metered multi-dose dry powder inhaler, like Ziphaler or AccuHaler, there will be, every dose will be separately placed and only that dose will come out. There are advantages and disadvantages for each of this. So you may currently ask, which is the best device? எனக்கு இவ்வளோலாம் வேண்டாம், எனக்கு எது best device சொல்லுங்க, அது மட்டும் நான் என் பேஷண்ட்டுக்கு சொல்லி கொடுக்குறேன். That's the simplest format. Whichever is the patient is using the best is the best device for you. That's simple. So that may change according to each and every patient. So I've shown you here a multitude of dry powder inhalers, single dose, which is nebulizer, rotahaler, handyhaler, and the cyclohaler and the variants is basically called cyclohaler, but the Lupin company brought it here first, so it's called loopyhaler. So every company which brings in the device puts their name. Like MacLeod, if they bring it, it becomes a MacHaler, and similarly it goes on. So there are multi-dose DPA devices which are called in different names. This is, I am taking a one single company's progress from the year 1958 until now. You can see 1978 was the year the first salbutamol inhaler was produced by the Indian company. And from there are at least 25 to 30 medicines, devices, and newer medications have come through. All of it will be confusing, more so to the general practitioner. See, I am a respiratory physician. I need to know this, but I need to know only this. I don't have to know about cardiac medicines. I can just simply say, I'm a respiratory physician. I don't know cardiology. You can go to a cardiologist. I can say, you can go to a neurologist. But for the general practitioners, they need to know from head to foot whose job is the most difficult, because they need to know, do this at a much shorter time and in a much quicker way, getting much less charges. It's always a difficult thing for a general practitioner. So let me simplify this huge group of medications, they're there. So it is all confusing. We will come back to this in next 5 minutes. So let's just say, which are the various routes of administration for asthma and COPD. Now you know the multitude of medications which are possible, which can be given in this slide, which shows you the different groups. There is a beta-2 agonist, there is an anticholinergic, there is a short-acting, there is a long-acting, there are multiple drugs. This is confusing, right? I would say confusing for everyone. Okay, now let us just simply ask, why should we use inhalers at all? It's simple question. It's much easier, right? So which are the various routes of administration for asthma and COPD drugs? So one is oral, second is inhale, third is parenteral. We all have used our oral and parenteral medications most often, and we use inhaled medications less. So what are the oral medications available? Tablets and syrup format. Inhaler, of course, I just we gave an overview of that: meter dose, dry powder, nebulization, everything. So parenteral is either an IM injection or an IV injection. So which is the best route for an anti-asthmatic drug? The global bodies, the GINA is the Global Initiative Against Asthma, and GOLD is the Global Partnership Against Obstructive Lung Disease, which is COPD. They recommend inhalation medication as the best way of giving medications to both asthma and COPD. And they also say assessment and regular evaluation of inhaler technique, which has a direct impact on therapy outcome. Both the inhaler technique and the adherence to therapy is equivalent to therapy outcome. Why is this inhalation therapy the preferred route of administration? So oral or inhaled, let's say we are using our tablet Astelin, which is 4 milligram or it is 4,000 micrograms. So there is Astelin inhaler, which uses 100 microgram of puff into 2 puffs, which roughly translate into 200 micrograms. So in one tablet of Astelin 4 milligram, we can actually use 10 times into 2 puffs, that is 20 puffs of Astelin inhaler. So this is simply 20 times less drug is required for the same effect from the inhalation route compared to the oral route. And we also will see how an inhalation medicine works. Let's just see, oral is large dose is used compared to inhalation, where it's a small dose which is used, greater side effects and lesser side effects because of lesser dose being used. There is a very slow onset of action because it has to reach the stomach, then go through the bloodstream to act on. There is a fast onset of action in inhale because it reaches the spot directly. Not useful in acute symptoms, where inhaled medicine is useful in acute symptoms. This is the advantage of inhalation therapy over oral route. So there is a direct action on the lungs and a quick onset of action, and the small doses required. There is a minimum side effect. I hope you can hear me well.
Yes, sir. Hearing you, sir.
Yes, Nandu. Yes, Nandu.
Yeah, I just suddenly thought something is went wrong. Okay, sir. So advantages of inhalation therapy over oral route is there is a direct action on the lungs with a quick onset with small dose with minimum side effect. Now you would agree that there is a difference between the DPI and MDI also. Basically, let's not go into that on a big way. We'll look at the patient factors, the technique of the use of the device. What determines the best device or best medicine is the way the patient is using it. The patient, whatever the device the patient uses the best, is the best device for that particular patient. It is not you're limited to one device which will be fit for all. There are some patients who use MDIs extremely well. There are some patients who say, no, I want the DPI. I want only particular in the rota hailer kuda எனக்கு நல்லா வேலை செய்யுதுங்க. நீங்க அதோட நல்ல மருந்து தான் கொடுத்தீங்க டாக்டர், ஆனா எனக்கு அது என்னால யூஸ் பண்ண முடியல, அது எனக்கு வேண்டாம், எனக்கு இதுவே கொடுங்க. So whatever is the patient, but again the technique also needs to be assessed by yourself. Is the patient using it correctly? So this is as per the particle size, there is a difference. So if it is more than 5 microns, the most of the deposition happens in mouth and esophageal region with no clinical effect. If it is 1 to 5 microns, there is a deposition in the upper and central airways with clinical effect with subsequent absorption from lung. If it is less than 1 micron, it reaches up to peripheral airways and alveoli with high systemic absorption. So where it needs to be used. So if commonly the drug, again, one of the questions asked is the inhaled medicine, when I take, what happens to me? Even the patients take it, even there are some doctors who take it. Trust me, the best inhaler gives around 30% deposition. Rest 70 to 80% is swallowed, which is denatured in the track, not much used. So it doesn't get past the first pass metabolism in the liver, going into systemic circulation. That is, out of the 20% which goes into the lungs, there is only about 10% of it comes to the systemic circulation. So even out of 200 micrograms of salbutamol, which goes in, less than probably 20 micrograms come into systemic circulation. Then again, from systemic circulation, from liver to kidneys, it is eliminated. So this is the basic pharmacokinetics of these drugs, but it is less than 1/100th of the dose of oral medication which actually gets into the systemic circulation. Please remember that fact. If a patient who's using 1 year of inhaled steroids will be often using less than 1 course of systemic steroids of injections, what we give for an exacerbation. So airway structure is situated like that: smooth muscle layers, blood vessels, epithelial layers, and spongy layers. And if we have to go back into our nervous system, there are 2 types: sympathetic and parasympathetic. So sympathetic and parasympathetic arms act on the same organ, but in pharmacological opposition. We all would have read that and promptly forgotten by the time pharmacology was over. Me too. So what happens is, in the neurotransmitters, which is a sympathetic activator, and acetylcholine, which is a parasympathetic. So receptor which is on adrenaline axis beta-2 and acetylcholine is muscarinic. What is the effect of adrenaline? Bronchodilation. What is the effect of acetylcholine? Bronchoconstriction. So there is one sympathetic activator, adrenaline, which is causing bronchodilation, and there is one acetylcholine which is causing bronchoconstriction. So if we have to do a bronchodilation, either we have to give something which actually stimulates into producing more adrenaline, or that we have to give something which actually blocks acetylcholine, because the bronchoconstriction will get blocked. So either we have to give an anti-muscarinic agent or a beta-2 agonist, that is, which accentuates the adrenaline action, both of which will cause bronchodilation. Because we know that both in asthma and COPD, the bronchoconstriction is the problem. So there is a airway narrowing. In an asthma or in COPD, there is always a airway narrowing. One, that's caused bronchospasm. Second, there is a inflammation which is also happening in the airway. This inflammation causes the airway smooth muscle layers to swell up. So one aspect is that bronchospasm we are looking at causing bronchodilation. So what happens in COPD? Again, there may be different mechanisms, but at the end of the day, there is a bronchoconstriction which happens. There could be an obstructive chronic bronchitis, where is a bronchoconstriction, along with inflammation of the smooth muscle layer, maybe through different inflammatory markers, but at the end of the day, there is a bronchoconstriction. Or there could be an emphysema, where there is a damage to the alveoli and the air actually becomes trapped. Why it becomes trapped? Because of bronchoconstriction and the respiratory mechanics, air is actually coming in, but it cannot get out. Because it cannot get out, New air cannot get in. As simple as that. If there are 100 people stuck in a room and nobody is willing to go out, there is no place for the 101st person who wants to come into that room. As simple as that, there is already air which is getting stuck inside the alveoli, and that is got swollen already. There is an air trapping which is taking place. The new air cannot get in. So there is a decreased oxygenation which is taking place. So that is causing the effect in emphysema. So there is a chronic bronchitis subtype and there is an emphysema subtype, both of which is causing the thing, which is maybe caused by different causes, maybe a cigarette smoke, maybe a biomass particulates, all of them using different inflammatory mediators, maybe neutrophils, maybe macrophages, causing lung inflammation, causing oxidative stress and proteinase secretions, resulting in COPD pathology, which we already saw it earlier. So we can give antioxidants, we can give anti-proteases for cutting down this. But at the end of the day, can we think that asthma and COPD, both of them have bronchoconstriction, both of them have different same mechanism but a different way, but end up having a bronchoconstriction and a smooth muscle inflammation. So are they same disease? No, they are not, because the age is different, the age of onset is different, smoking cause may be different, how the symptoms come, how the limitation is there, everything is different. There is a problem in screen sharing.
Now
it's got corrected.
Yes.
The diurnal variation is more in asthma and seasonal variation is more in asthma, which is not usual in COPD. There will be a persistent symptoms and usually progressive symptoms, not fully reversible. Airway limitation is episodic in asthma, it's often fully reversible. And the history of allergies and childhood asthma are more common in asthmatics, and the history of exposure to noxious particles or gases is more common in tobacco smoking. So this, most importantly, the asthma often improves spontaneously, intermittently at least, or with treatment. Whereas in COPD, it generally progresses over a period of time. So this is the basic difference. So how do we treat this? What classes of drugs are used? So we already discussed about two types. One is a beta-2 agonist and second is a anti-muscarinic agent, both of which will cause bronchodilation. So we also discussed there are two parts, both in asthma, also in COPD, bronchospasm and inflammation. So let's discuss about asthma first. In asthma, the bronchospasm, it needs a bronchodilator, which basically relieves the symptoms, because bronchospasm is the one which is giving the immediate symptoms, which is led by a bronchodilator. And there is a inflammation, which is a swelling, which needs an anti-inflammatory medication, which is basically going to act slow. So it is going to be a controller. And that inflammation, when it is slow but definite, it is going to cause a long-term relief with the symptoms. So we need both the bronchospasm for immediate symptom relief and an inflammation for controlling anti-inflammatory for controlling the inflammation. So what is the medicines which are available for reliever? Bronchodilators and controllers anti-inflammatory. What do they do? Bronchodilators quickly relieve symptoms. Anti-inflammatory basically prevent asthma attacks. Onset of action fast with bronchodilators, but is short acting. Whereas in anti-inflammatory, it's a slow onset of action, but it's a long acting. So relievers are known as rescue medicines and controllers are known as regular medications. Okay, now what if we can combine both and give in a single inhaler? Nothing like that. So what we use, initially we used relievers which act as separately. Okay, something like salbutamol and levosalbutamol. The common brand names which are available in the market are Astelin and Livolin, which are short-acting bronchodilators. Also, there are short-acting beta-2 agonists. That is more of acting on the adrenaline pathway. So to be taken as and when required. So there are controllers that are used in asthma as a daily treatment, which are basically regulates the inflammation. They are anti-inflammatory in nature. So what are the inhaled corticosteroids available? Beclomethasone, budesonide, Fluticasone, cyclisonide, and mometasone are available in India, along with the newer ones of variants of fluticasone. The anti-leukotrienes, which is a montelukast, which is very famous. Even after COVID, they are getting very, very famous, more famous. They are also preferred as an add-on therapy because they also act as an anti-inflammatory. So what are the combination medications are available? Along with fluticasone, we can add a bronchodilator. Along with formoterol, we can add a bronchodilator. Along with cyclisonide, we can add a bronchodilator. Like that, there are bronchodilator and inhaled corticosteroid combination therapies available, which acts both as the reliever and the controller. So when these to be used, to be taken regularly, even when the patient doesn't have symptoms. This is the basically the comparison of properties of each and every inhaled corticosteroid available. So what are the therapeutic options for COPD? Let's now talk about asthma. Asthma is very simple. You need to give reliever, you need to give a controller, then you need to give, you may choose to give a combination of both. So what are the options in COPD? COPD, first is the removal of the noxious particles and gases. So that is smoking cessation. In case where patients are already presenting late, oxygen is needed, home oxygen. Vaccines, influenza, pneumococcal, and other vaccines are very important because most of the time COPD presents very late in the presentation, and they also are more elderly people. So they may need pulmonary rehabilitation. So what are the basic pharmacotherapy available? More of bronchodilation, because this inflammation which is taking place in COPD is different from the inflammation which is taking place in asthma. Asthma, it is eosinophilic COPD, which is largely can be controlled by inhaled corticosteroids in a maximum extent, whereas in COPD, there are neutrophilic inflammation which cannot be controlled by the inhaled corticosteroids alone. So they need other options as well. So the other options are phosphodiesterase inhibitors and antibiotics. So this is an N-acetylcysteine as well. So if we pull everything together, there is a beta-2 agonist inhalers, which may be either short-acting or long-acting. There may be a anticholinergic inhaler, which is either short-acting or long-acting. There may be a combination of short-acting beta-agonist and a short-acting anti-muscarinic agent. And similarly, long-acting beta-agonist and long-acting anti-muscarinic agent. There is no point combining one short-acting with one long-acting because that will be almost like a foolishness. Okay, that's like running a car with different wheel sizes. So you need to have same kind of duration of action. So what are the other options available? So what we can do is, again, we can have a long-acting beta-agonist plus an inhaled corticosteroid, which are used in largely in asthma. Or we can also have a combination of a long-acting anti-muscarinic agent, long-acting beta-agonist, and an inhaled corticosteroid together. So which is a triple drug combination which is available. So there are multiple combinations available. So what are the things we are going to use now in asthma and COPD? These are too many options. Obviously, it's going to be confusing. So how to use this? How to go about using this? So we already discussed about one aspect. There is a clear airway, whereas in asthma, which is going to get inflamed and constricted. So there is a muscarinic receptor, there is a beta receptor in the airway. So either we need something which will activate the beta receptor, which can cause bronchodilation, or muscarinic, which acts against the acetylcholine. So it's called muscarinic antagonist. So there is also an effect of inhaled corticosteroid on the inflammation. So what are we going to use? Either something acts on beta receptor or muscarinic receptor or inhaled corticosteroid. So only there are 3 groups of medications which are available. So what are those medications? Whatever which ends with IUM, tiotropium, ipratropium, glycopyrronium, maybe ends with EUM, which is an anti-muscarinic receptor. It's a very simple thing to learn. We all would have learned about our beta blockers. Like அப்போ ஜோக் சொன்னாங்க, அட்டின்லால், ரோஷன்லால், வேற ஏதாவது லால் இருந்தா கூட அவங்க பீட்டா பிளாக்கரா தான் இருப்பாங்க. அதே மாதிரி தான் பீட்டா ரிசெப்டாருக்கும். Anything which acts ends as OL is a beta receptor. And most often anything which ends as a ONE is a inhaled corticosteroid. So what do? In COPD, we need to use the bronchodilators first. So it needs to be a long-acting anti-muscarinic agent, then add on as a long-acting beta-2 agonist, then add on inhaled corticosteroid. So this is the first step, that is the second step, and that is the third step. So this is the pathway for using in COPD. As the severity increases, we can initially use a anti-muscarinic agent, then we can use a combination of anti-muscarinic agent along with the beta-2 agonist. Then we can add on finally inhaled corticosteroid if the situation warrants. So in asthma, it is usually the other way around, because there it's a eosinophilic inflammation, which is the main problem. So the first step is going to be the ICS, inhaled corticosteroid. Then if the inhaled corticosteroid alone is not working, then the next step is the long-acting beta-2 agonist. And if both of them are not working enough, or it's not enough, we need an additional medication. We can think in terms of an anti-muscarinic agent. So this is the way it goes in asthma. So there are only 3 groups of medication which acts on each other. Okay, sir, patient costly drug we can use at least a short-acting beta agonist and short-acting anti-muscarinic agent together, which is very commonly used is a levosalbutamol plus ipratropium combination, which are available in various combinations, which are available at a lower cost. And levosalbutamol is pure therapeutically active form of salbutamol, quick onset of action, binds to the beta-2 receptors and causes bronchodilation, useful in management of both asthma and COPD. Ipratropium works on cholinergic tone, only reversible component of COPD, where it prevents bronchoconstriction and causing bronchodilation, and works on the central airways. So if you add both, one which acts on the central airways and one which acts on the peripheral airways, it will be much better combination. So this is the mechanism of action, both of which one is causing bronchodilation, other is preventing the bronchoconstriction, both by opening up airways and prevents airways from closing. So this is giving a total airway coverage. Basically, this will work even better with the spacer. Spacer, when PMDA is actuated, that's a pressured meter dose inhaler is actuated, aerosol cloud produced from the spacer device is finer and slower moving. That results into the evaporation of propellants. This spacer, as shown in the picture, it actually holds the drug in one place. It makes it easier for the patient to take in and increases the amount of drug deposition. The need for the spacer is because it's MDA usage technique dependent. We can use spacer correctly. Even doctors, most of the doctors cannot use a PMDA correctly unless trained very well. And if the PMDA is not, that MDA is not properly, technique is not correct, the drug deposition in the lungs is very minimal, and the best medicine cannot act unless it is given properly. So this spacer actually overcomes the need for the coordination, and reduces the technique need and holds the medication for a longer period of time, and it also reduces the side effect. Who should use spacers? Patient with coordination problems, very young and the very old. And those who are prescribed high dose medicines, those better to use a spacer to avoid side effects. And if they need a high dose bronchodilators, which can substitute for a nebulizer, which can again in a hill area, let's say the patient access to a nebulizer will be very difficult, or in a remote area, they can use spacer. So again, there are multiple spacers available in the market with plus and negatives of many things. So let's not go into that. I think I'm already overshot my time, so let me just rush up.
Yeah, in a couple of minutes you can finish, conclude. And sorry to disturb you. In a couple of minutes you can conclude.
Yes, sir. Yes, sir. What are breath actuated inhalers? There are newer in the market. It actually combines the advantage of both inhaler and the rotahaler. It overcomes the problem of coordination, operates at a very low inspiratory flow rate, and the age-wise we can divide them into less than 4 years, means it's definitely a spacer plus face mask has to be used along with the meter dose inhaler. The alternative choice always available is nebulizer. 4 to 5 years MD with spacer. I prefer 12 years with MDA with spacer only to avoid side effects. And as per the JINA report, it's a 5 years and above, either a dry powder inhaler or a MDA with spacer. So, but my personal preference, if you ask me, I'll say up to 10 to 12 years, I use a MDA with spacer. The alternative choice available is a nebulizer. Yeah. Sir, I think that's about it, sir. Thank you, sir.
Thank you, Nandu, for this wonderful presentation on the inhalers for the obstructive airway disease. Now, may I request scientist Dr. G. Narendran, pulmonologist and scientist, Senior Deputy Director of ICMR, NIRT, that is a National Institute for Research in Tuberculosis. Previously, we called it as TRC, TB Research Center. Now, NIRT. He is Deputy Director, Senior Deputy Director of the ICMR NIRT. And Dr. Narendran is MBBS, TTCD, DNB Respiratory Medicine. And he did various studies, clinical studies about the TB, HIV, declaration tuberculosis, etc. Various research papers, national, international conferences, have many awards and all. So with that, may I request Dr. G. Narendran take over and start your presentation. Over to Dr. Narendran. Thank you.
Sir, am I audible?
Yes, Narendran.
And what about the slides, sir?
Yeah, slides are visible. You can make it to full screen. Yeah.
Right, sir?
Nice, fine.
Yeah. So it's always a tough time to come into the slogovers. So I have very little time for me to share my slides. So I'll just rapidly run through. So if anybody has any doubts, please bear with me, and I have shared my email, and so it's easy for you to contact me. And my esteemed colleague, Dr. Jairam sir, is there, so you can come through him also.
Thank you.
First of all, my disclaimer that this is all my opinion and nothing to do with my institute. So going to the diagnostic dilemmas between microbiology and radiology, always we have a confusion with this with respect to X-rays. So if you take the X-rays, these were patients who were referred to us, but all of them turned out to be, they are all non-tuberculosis cases. The first case, if you see, due to short of time, I have to run through the slides. The first case, if you see, is just a case of aspiration pneumonia. The next two cases are actually pneumoconiosis. The lower down cases are actually secondaries with, you can see the shallow pneumothorax. This is a case of pectus carinatum resembling middle lobe syndrome, and the other is a classical hepatopulmonary amoebiasis. So can a chest X-rays be normal in TB? Sometimes we have the usual question that X-rays can be normal in endobronchial tuberculosis. But actually, it's a wrong fallacy, because endobronchial tuberculosis, actually the seedling is from the lung into the tracheobronchial tree rather than from the tracheobronchial tree into the lungs. So when can chest X-rays be normal? The only condition where we have seen is immunocompromisation, whether it could be HIV or patients on long-term immunosuppressants, renal transplant patients. In all these patients, you may still have an X-ray normal with the culture being positive. We have actually published a paper in HIV where we found that 14% had culture positive tuberculosis, but being normal, especially if they are in advanced stage of HIV. But you have none. That's the take-home message. Who are immunocompetent, who have a normal chest X-ray. If you can thoroughly read the X-ray.
Excuse me, Narayan, sorry to disturb you. Can you increase the mic volume from your side, or you keep the mic very closer to you, Narayan? Thank you.
Yes, sir. Yes, sir.
Thank you.
This is another case where mediastinal adenopathy, usually we call it, whenever you have mediastinal adenopathy in HIV, they are always pathological. You cannot say it's part of the progressive generalized lymphadenopathy. So what are the clues to say that somebody is immunocompromised? If you look at the CT scans, this was one of the patients on the left side who had a CT scan looking like cystic bronchiectasis. Actually, you can see cystic spaces. But this was a patient surprisingly with MDR TB. You can see then we were puzzled why the patient presented with this kind of a thing. But actually it was, this patient was on SLE with enough immunosuppressants. You can see that the patient does not have satellite nodules. You can see that the patient does not have any other evidence of tracheobronchial invasion. The other one is miliary TB. If you can see the other side of it, miliary TB with multiple classical nodes. Now, all these are in favor of immunocompromisation. That is how you have to diagnose with respect to chest X-rays. And radiological watch is as important as bacteriological watch because it immediately gives you a clue to what you are dealing with. This was one of the patients with MDR TB. Patient was treated and suddenly developed. You can see in the left side, I may have my cursor. Sir, are you able to see my cursor? Hello?
Yes, Naren. Yes, Naren. Cursor, yeah.
So suddenly you can see that the mediastinal nodes are enlarged and there is the mediastinum is enlarged, and later we found out that the patient has got classical SVC syndrome. And then we took a CT and found out that this patient almost has a collapsed SVC. So we did the CT, and CT clearly showed the mass lesion, and PET CT confirmed it to be malignancy, and then we did the biopsy and found out to be a small cell carcinoma in a patient who already had successful treatment for MDR TB. So don't go under the impression that if the patient has got TB, this is all you see in the chest X-ray. So what about extrapulmonary TB? Can we fuse radiological tests? CT has got its own limitations in the sense that you may have subcentric lymph nodes which are not visible usually on the CT, but you can club it with the PET CT in case you have patients who have PUO, especially where you want to rule out tuberculosis. Again, for prognosis, you can see that this is a patient with multiple lymph nodes, and after treatment, you can see that the nodes, you do not see these lymph nodes in the axilla or anywhere else in the abdomen. So it can be used as prognosis also. To find out immune response inflammatory syndrome, this is one of the patients who had, these slides I have borrowed from my colleague, Dr. Santosh, where you can see the mediastinal node, and like volcanic lava, you can see the pericardial effusion which is developed from the breakdown of the mediastinal node. Sometimes MRI comes into the rescue. Nowadays, people don't go for a biopsy or anything like that because you can't do a brain biopsy. Obviously, it will hit on some place because your brain controls some part of your system. So when you have pictures like this, where you suspect tuberculosis, if you ask for MRI spectroscopy, it's very easy for you to diagnose tuberculosis from other lesions like toxoplasma, etc. Artificial intelligence, everywhere we are talking about artificial intelligence. Now, this is the future where we were fortunate to work initially, but due to lack of funds, we could not proceed. Clifton-Berry group, where by using artificial intelligence, they were able to create metabolically active bacteria, where you can say this is the group which have pan-sensitive tuberculosis, and this is the place where drug resistance is emerging. So, but this is still in the validation phase. Now, coming to the bacteriological side of it, now you can see that this is the classical AFB stain, and this is the fluorescent stain, and you are now gone to Gene Expert, and tomorrow maybe we are going to breath analyzer and whole genome sequencing. So it's also important for us to diagnose TB in the extrapulmonary specimen as far as possible, because this is otherwise it keeps confusing. For example, lymph nodes. If you start steroids before making a diagnosis, the entire histopathology of a lymphoma may be totally masked by your steroids. So this was one of the patients, especially if the patients are immunocompromised, it's easy for you to look out for nodes. This is one of the patients with axillary node. We did the guided biopsy where you could see the AFB. This is again one of the patients who had panophthalmitis. He has patient with advanced HIV, where you can see the hyphema in the anterior chamber. The entire, we had to enucleate his eye because of extreme pain, and we could see the entire choroid was filled with AFB. Then what are the newer advantages? You can see that, give me 1 second, so I'll just get this on. Now, what are the advantages of the Expert, the Ultra, the TrueNut, etc.? The advantages is excellent sensitivity, very good specificity, and you have the diagnosis and drug sensitivity in one go. But the disadvantage is that when you are using Expert, you should always take it with a pinch of salt if your Expert is again positive in the second time during treatment. The sensitivity pattern, yes, but not the detection, because let us take, you have a small piece of paper, I put a small dot in it. If I ask you what it is, you will say dot. If I take a huge piece of paper, almost as the size of a room, again put a small dot, again you'll be able to diagnose this as a small dot. Reason why I'm saying is that the mycolic acid is being amplified to such an extent that the machine is sensitive enough to detect that. That doesn't mean it could be to dead bacilli. It doesn't mean that it should be a live bacilli. You have certain techniques called the fluorescent diamine stain. It's called FDA stain. It's called viable stains, where the bacilli has to take the dye if it is alive, and then we can find out that it's bacilli alive or dead. The other thing is extrapulmonary drug resistance. Always take it with a bit of caution, especially if the patient is very sure that he has not taken any previous treatment. Of course, this was something which we found out when Gene Expert came into the market. At that time, all these patients were already on sensitive treatment and almost had completed. And then later we found out that these patients had Gene Expert positive and RIF resistant, but they had actually as per the treatment was success, the lymph node had regressed already. Again, Gene Expert is very poor in finding out extrapulmonary, that is to find as a diagnostic tool for extrapulmonary sample, especially pleural fluid. It has got very good value for lymph node tuberculosis. It's got very good value for almost in the middle bit for abdominal, that is peritoneal fluid. I'm sorry, for meningeal TB. But as far as peritoneum and pleura is concerned, it's a little dicey. It's only around 45% sensitive. This is the accuracy based on various body fluids and specimen which we have got. Now, this is the rule of 1, 2, 3, which I myself had formulated for the ease of remembering. People think that Gene Expert is like a magic bullet; it can diagnose everything. But you have to be very careful when you're sending it, because these are the criteria which you have to be. Number one, not less than 1 ml of specimen, that is sputum. That is, I'm primarily now concentrating on pulmonary tuberculosis. Number two, at least less than 2 to 4 degrees temperature when it is being transported. And 3, you do the test within 3 days of collection. Very, very important to remember, especially with tuberculosis, that patients with blood type sputum, the heme of the blood can interfere with your Gene Expert and you can have a falsely negative Gene Expert. The other advantage of Gene Expert is if you are Gene Expert positive, it rules out most of the non-tuberculous mycobacteria except the Mycobacterium complex. We also now have standard ways of doing the same Gene Expert technique for other second-line drugs which are available, so you can get that also in no time. So these are some of the patients with tumors where abscesses, which very commonly we see in the liver and the lung, teeming with bacilli, and these are the best places where you can do aspiration, and provided the patient's coagulation profile is normal, and then you see that the patients have Gene Expert positive or even smear being positive. This was one of the, just to give an example of the advantage of Gene Expert. Now, this was one of the patients who came to us, his state volleyball team. When we did the Gene Expert negative, and that prompted us to diagnose lymphoma. And true, when we did the
polycystic vitreous, pleomorphic adenoma, right parotid gland. Yes.
Can I continue?
Yeah, please, Naren, please continue. I request all the delegates mute your mic, please. Naren, you please continue.
Yes, sir. Thank you. So this was a case of actual lymphoma. So most important to remember, especially with lymph node tuberculosis, one is very commonly is lymphoma. As our Professor Dr. Asen used to say, lymphomas can coexist with tuberculosis. Lymphoma can start after tuberculosis. And the other thing is also true that lymphomas can trigger an occult focus of tuberculosis, and post-chemotherapy lymphoma, tuberculosis is very common. So they have a very good coexistence. Now, what are the consequences of ignoring MTB? You cannot be too ambitious to say that, no, I don't want to see the Gene Expert. This was one of the cases, it was a case of, luckily the ball was Gene Expert positive, and they found out that this patient he also had a mediastinal lymph node. But the rifampicin sensitivity pattern came as resistant with the Gene Expert, and this was the patient was started on somehow inadvertently on first-line therapy. You can see now it has totally, the patient has deteriorated, and you can see that now you have so many parenchymal lesions cropping up. So that is where you have to be really careful with Gene Expert. Now, mycobacterial growth indicator tube is the MGT, as you know, because BACTEC has gone into non-existence because of the difficulty in clearing the radioactive material. Now, the mycobacterium growth indicator tube is an automated tube, like instant coffee. It gives you the value whether it's positive or negative. You don't have to keep looking at it. All that you need to do is look at the indicators. Now, what are the advantages of this kind of liquid culture? The advantage is that You can have the drug sensitivity pattern for drugs like pyrazinamide. It's only available through this method. It's self-automated, so you don't have to, like an automatic analyzer, there's no manipulation. So you have more advantage being more accurate and you get faster results. That is within a month or so, you can get the culture sensitivity, culture positivity and then sensitivity pattern as well. But the biggest problem is contamination rate. So the usual contamination rate allowed is 5%, which you can do only if you have a BSL-3 lab. Otherwise, it'll be very difficult. And setting up a BSL-3 lab is it's a problematic issue in a normal hospital.
Sorry to disturb you. So mic is slightly low volume. Can you adjust the mic, or you just close to the mic? You can speak, Naren. Sorry, extremely sorry.
Sorry, sir.
Extremely sorry. Right. Now is
the other problem is the high contamination rate. So if you look at the other problem is not only high contamination rate, that it requires a slightly higher bacillary burden compared to the usual conventional culture methods. If it's 10 power 2, it's somewhere between 10 power 2 and 10 power 3. The biggest problem is looking at the colony morphology, as we have been taught as the rough, tough, and buff colonies. The colony morphology is different in if you look at the slope of the Lowenstein-Jensen medium. You can diagnose NTM straight away, but here it is not possible because everything is happening inside the machine. And if you need to do a subculture to find out if it is NTM or not, that also is difficult with the MJ. And the latest is the whole genome sequencing. You have different platforms where the entire genome of mycobacteria is thrown so that, but still it is not easy for us to interpret the results. This is the problem. This is how the results will come with the WGS and other things. And by the time you diagnose and have this problem, find out how much of them are you dealing really with the drug sensitive or drug resistant bacilli, you become dizzy. So finally, what we take to the patient is nothing. The last one is the micromorphology. That is doing electron microscope, where the Proteus group is working on this. So it is from their slides from the UK, where you can see that looking at the morphology, they can say that whether it belongs to the actively replicating, the intermediately replicating, or the late stationary phase, or totally non-replicating bacilli, or the dormant phase. So this is how they replicate. Each one has got its own advantages. Because of short of time, I'm not able to stress it, but just give you just a glimpse of chemotherapy of TB. If it's active phase, you can give all the drugs. But if it's late stationary or stationary phase, only certain drugs act. For example, rifampicin, rifampicin, pyrazinamide, bedaquiline, delamanid, like that, linezolid. If it's a non-replicating phase or a dormant phase, no drug acts. So if you're going to shorten therapy, you have to use drugs like the previous lecture. What type of drugs are you going to use when you're shortening therapy, and what is the problem with the patient? Is he relapsing, or is it a reinfection, or it's a true relapse? So based on that, the drugs may change in the future. For that, it may be required. So just to give you a glimpse that yesterday, I was interested to see the Hindu where they showed there was a thing on multiple, there is increased incidence of myocardial infarction among post-COVID. So this is what we are doing using the Q-SPECT, where we are trying to find out whether the patients are prone for heart attack, and we are getting some early leads because of the research. I'm not able to divulge more than this, but very soon you will hear from us with respect to this. So because of short of time, I'll just stop with this, and thanks to everyone, because this is something which you already know. It's not something which I'm just updating or revising your knowledge, and it has been a good time. And thanks to Jayaraman sir for giving me this opportunity, and thank you all.
Thank you, Dr. Narendran, for this wonderful presentation on the tuberculosis update to commemorate World Tuberculosis Day. So wonderful. You're all very busy with research in ICMR, I know well. So thanks for coming and address our IMA audience. So this is our very, we're grateful to you. Thank you very much. Now we have questions to both the speakers, Dr. Nandagopal and Dr. G. Narendran. Regarding the our teacher, Dr. Sundaramurthy sir, asking two questions. One is to Dr. Narendran. Naren, how common atypical presentation of tuberculosis in immunocompetent patients?
My knowledge is restricted to HIV, sir, because we've been dealing with HIV patients for over 15 years. So just a rough rule of thumb is if your CD4 is above 400, you have typical TB and typical presentation. Let us take somewhere between, let's say, between 150 to 400 or 150 to 250. Then you have typical TB and atypical presentation. If the CD4 is less than 150, you have atypical TB, atypical presentation, or typical TB, atypical presentation. This is how it goes.
Thank you, Naren. As per the WHO and other countries' statement that we have to eradicate tuberculosis (NTB) program in 2025 or 2030. So, what's your aim? Is it possible to eradicate TB completely? We can end the TB disease, Naren.
Sir, we have to be optimistic because unless you dream, like what Abdul Kalam said, you may not achieve anything in the end.
Yeah, correct.
We have to work hard.
Thank you. Nandagopal, Dr. Sundaram is asking one question. Role of a short-acting muscarinic antagonist and long-acting muscarinic antagonist in asthma. Nandu?
Can you hear me?
Yeah.
Yeah. Can you just please repeat the question?
Yeah. Role of short-acting muscarinic antagonist and long-acting muscarinic antagonist in asthma.
In asthma, basically, the first line of action is inhaled corticosteroid, and second is addition of a long-acting beta agonist along with inhaled corticosteroids. In cases where both of them, even at high doses, don't work, then anti-muscarinic agent can be added to see if there is a better bronchodilation and better relief of the symptoms. In case, before jumping on to the biologicals or any other options available, that's just an add-on option, that they're not a straight but in the latest classifications, long-acting anti-muscarinic agents are being given as a step 5 treatment.
Nice, very good. One more question Dr. Sundaram is asking about the role of LTI in COPD. Role of LTI, I think leukotriene inhibitor, no, in COPD.
I'm not sure the guidelines are recommending any LTI in COPD assets as of now.
Fine. Okay. Yeah, correct. Dr. Girija ma'am is asking one question, Dr. Nandagopal. Does Budicort inhalation cause diabetes later life? Inhaled Budicort can cause diabetes later.
See, there are papers which are suggesting the inhalation medication linking them with diabetes, but I would say suggest dosing of the inhaled medications which are available and if you calculate the dose and the effect, systemic absorption ratios and the effect, I would say it's highly unlikely unless if the patient is abusing the Budicort inhaler, like going through one a week or something. Other than that, it's not possible.
Yeah. But Girija, I'm asking one more question, the same way like Budicort inhalation. How long can be used after an attack of wheezing, sir? I think this is related to the Budicort, I think. How long Budicort can be used after an attack of wheezing?
No, basically, we would recommend as pulmonologists to take a lung function test, classify the patient as an asthma or COPD using the history, clinical examination, course of the disease, and using a spirometry. Then use the medication for as long as the patient needs. So there are people who are using inhaled medications for more than 30 years on a regular basis. So it hasn't resulted in any major side effects. Or yes, of course, there are, I can't say they're side effect free medications, but it can be safely used in therapeutic doses for a very long time.
Okay. So one more question from Dr. Abhinaya. Is long-term Montelukast usage having positive effect over prevention or exacerbation of bronchial asthma?
Sir, if the long-term usage, I would prefer to use an inhaled corticosteroid rather than using a Montelukast. So the for prevention of asthma, yes, inhaled corticosteroids are the first line indicated, and the current GINA guidelines clearly say that there could be a combination of the inhaled corticosteroids plus long-acting beta-2 agonist. So that's a first line. Yes, alternative treatment, Montelukast can be used, but Montelukast does have its own side effect profile, particularly more of a neuropsychiatric untoward effects are now coming out in the open. So for long term, I would think twice, thrice. Rather, before using before using budesonide or fluticasone as a controller inhaler, I would not jump in and use Montelukast as a first choice.
Okay, fine. Another question from Dr. Sumati Krishnamurthy. Is there a role in climatic changes for asthma? If so, hill regions are more prone or polluted urban areas?
Again, there is a combination of an external and internal factors. Like there are people who have gone to the coldest areas and stayed symptom free, and there are people who vouch that I am totally free in my town. The moment I step into Coimbatore, I have a problem.
Okay.
So it's a combination. So you can't really say that. Yes, there is a climatic change. That there are external factors which play a role.
Okay. So a question to Dr. Naren. A patient complains that her voice is not able to use for high-pitched voice. History of treated for 2 times. I think patient had some tuberculosis treatment 2 times, some voice issue. So I don't know exactly what question she's asking, madam is asking. Naren, can you note that question? A patient complains of that her voice is not able to use for high-pitched voice.
Sir, I just looked at the chat box also.
Yeah, okay.
The person can clarify further. I'm also in the same this thing. So all that it is, remember, there are 2 things with TB. Whatever treatment you give for tuberculosis, that's why we are looking at different perspective in the sense that how much of structural damage can be avoided when we are using other drugs. For example, let's say metformin as an adjuvant for anti-inflammatory drugs. There are certain drugs which you have to use. The human necrosis factor alpha 1 antagonists have failed miserably because they cause relapse. So see, it's a structural thing where some of the patients, especially when they do a biopsy for the mediastinal node or when they treat the node, sometimes it enlarges and impinges as cause some. I've heard of hoarseness of voice. That's what probably she means by saying that patient's high pitch voice has gone. But there's got nothing to do. It doesn't say whether it is actually, I would say, as a complication or sequelae of the architectural changes in the lung caused by tuberculosis rather than TB as such.
Okay.
Stuff you keep treating the patients thrice, and then more to do with you have to do a CT, probably take a cardiothoracic opinion on that.
Okay, fine, Naren. One more question. Is it possible to diagnose as extrapulmonary? I don't know what's the full question. Just to read the.
No, is it possible to diagnose extrapulmonary tuberculosis?
So that's the question which actually I was showing the slide. Probably.
Yeah, kindly mute yourselves.
Probably that's a fantastic question in the sense that's why I actually showed a slide. Probably I was hurrying up with the reason is that you should make every attempt to see where you have a diagnosis of tuberculosis in extrapulmonary specimens also. But a lot of times I do with you, it's not easy for us to. Most of the times we start empirical treatment for TB. The question is that when you do that, finally, when the patient lands up with toxicity, then you rush up to the chest specialist saying, this patient is what happens. But you don't know how to manipulate the drugs because you're already in a jinx. To the extent possible, it's always better that you do specimen biopsy of the specimen wherever it is applicable, or do some invasive or semi-invasive procedures diagnosis. That makes life easy as you go about, because treatment takes around 4 to 6 months now and 6 to 9 months in case of MDR TB. Complication toxicity. The other most important thing which I wanted, which I probably have missed, is that when you're sending a specimen for gene expert or culture, especially extrapulmonary specimen, it should be in formalin. Most of the surgeons want, the commonest mistake is to send it in formalin. Formalin will kill the bacilli, so at least partly will inactivate, make it non-viable. You may not have a growth. So it's always good for you to send it in saline as far as the culture. It's not a histopathology which you are looking at.
Thank you. Thank you. Yeah, question to Dr. Nandagopal. How long should asthma preventive therapy using ICS LABA? Nandu?
There is another question also. I was just looking at.
Please read.
There is a question on oral candidiasis.
Yes.
See, oral candidiasis and inhaled steroids. Yes, the incidence numbers are not clear as far as India is concerned. But in a patient who is very elderly, whose technique is not poor, and patient who's on using really high dose steroids, and patient who's got other immunocompromised status such as diabetes, HIV, CKD, on dialysis, patients who are using inhaled steroids, the incidence of oral candidiasis is much more common. And the incident prevention is very simple. They can use a spacer. They need to gargle well after use of inhaled corticosteroid, and if possible, use it before taking food so that some of it gets washed off. So these are some of the preventive measures. And switch to lower dose of inhaled corticosteroids, probably with a combination rather than using a isolated high dose inhaled corticosteroid in such patients. So that is as far as that question is concerned. Second question is on how long to use. It is again, it depends. See, you need to really wean off in a very gradual way. So assess, reassess, reevaluate, then a step down. So the stepping down can be very gradually done. Probably some people it can be the people can be exacerbating only in seasons. For other seasons, we can actually come down. We have seen patients who take medications only for those particular months. Basically, patients themselves wean off in before even coming to the doctor. They decide, okay, I'm well and I'm There are certain patients who do use it for a long term. In them, you need to step down gradually, then reassess. In asthmatic, yes, it's very simple. We can use a peak flow meter or a symptom ACQ score, symptom scoring to see whether they have any symptoms. And if there are no symptoms, then reduce. No symptoms, then reduce further. Like that, we can be weaned off.
Yeah. For ICS-LAMA combination, there are a lot of drugs available nowadays, once daily preparation. So well-controlled asthma, we have to maintain with the long-term single dose, once daily inhalation. So this is the recommendation from the GINA guidelines. Anyway, right. One more question to Dr. Naren. Dr. Sundaram sir asking about impact of COVID on tuberculosis. COVID and TB.
Yes, a pleasure to answer Sundaramurthy sir question because he was our Dronacharya and we are his disciples.
Yeah.
So the thing is, if you look exactly at what COVID has caused to TB, it is first thing is that it has affected TB as good as any other disease. For example, patients were not able to go freely. There was a taboo, fear of COVID. So because of the quarantine measures and other things, people fail to, or people are afraid to consult for the cough and other things. So it was a question of more of patients now reporting due to various lockdowns, other things. There's an increase in the number of cases reporting. The second thing is that we are also seeing extensive lesions of tuberculosis. It's not that probably because of these reasons, the reasons are multifactorial. We cannot straight away say that because of COVID has actually flared up. But on the other hand, I can say that we are seeing these cases, but it requires some time for us to analyze whether it's because of COVID or a direct impact of COVID as such. But as far as the resistance pattern is concerned, we are not seeing a huge thing. It's more of socioeconomical and demographic complications caused by COVID to any other disease which is happening as such. It's not like myocardial infarction of COVID or something like that, which we have to analyze each of these reasons to see if there's direct attributable cause of COVID causing these problems. But the X-ray features definitely show extensive TB disease nowadays compared to pre-COVID era.
Thank you, Naren, for this wonderful answer for the impact of COVID on tuberculosis. So, if there are no questions, we can close the session. I thank Dr. Narendran for this wonderful update on tuberculosis, and Dr. Nandagopal for this wonderful update on common disease, asthma, how to use inhalers, how, when, what, and all. So, thank you all. Over to Dr.
So, kindly unmute, sir. Kindly unmute, sir.
Sorry.
Yes, sir. Sir, not able to hear you, sir.
Okay.
Yes, sir.
Yeah.
Yes, sir.
Yeah. Thank you. We had a wonderful presentation by Dr. G. Narendran and Dr. Nandagopal, the common disease, asthma and tuberculosis. So to commemorate World TB Day and World Sleep Day, we had three topics. So concluding remarks from me. So my role is vote of thanks I have to give now. So thank you, Naren, for this wonderful, valuable time to spend on our IMA platform. We are all so very fortunate people to listen as a scientist wordings of update of tuberculosis. Thank you. Nanda Gopal, our course coordinator. So thank you, Nandu, for this wonderful. I thank all our IMA leaders, delegates for this wonderful faculty for arranging nice webinar Zoom. I thank our State President Satamil Pari sir and Secretary Inna sir and our CGP team, mainly Dr. Senguduron sir and the Dynamic Secretary Dr. Sendil Kumar sir, CGP Faculty Secretary Dr. Sendil sir for this wonderful opportunity to combine meeting with the College of General Practitioner and the Academic Committee. So thank you very much all the delegates and our technical team, G. Kumar IT and other expertise, other stalwarts of IMA, all doctors. So thank you very much. Have a nice day. God bless you. Long live IMA. Thank you very much. Bye. Any question you can later on you can post the questions to the Dr. Narendran or our course coordinator Dr. Nandagopal or me. Thank you very much. Thank you.
Yeah. Thank you, sir. Thank you, sir.
Thank you. Thank you very much.
Yeah. Thank you, Naren, sir. Yes.
Thank you, sir.
Thank you, Naren. Nandu.